good clinical practice. She is a certified master trainer of PG certificate course of diabetic educators, Project of USA. She has been an invited speaker and moderator in various nutrition sessions. A large number of students have been trained under her. She holds research experiences in relevant clinical trials and in various nutrition surveys, which helped in benchmarking the clinical nutrition practices in the hospital. Several publications and papers of her have been published in medical and clinical nutrition journals. Now it's time to grab the first lecture of the day. We feel very much delighted to receive Ms. Hajarika and hear her on the topic entitled ICU Nutrition Dietitian's Perspective. Before starting the lecture, I would request the participants to mute yourself and turn off your video. You can post the questions in the chat box of Google Meet as well in the YouTube platform during the session. After completion of the lecture, we will deliver those to our honorable speaker. So, welcome, ma'am. The platform is eagerly waiting for you. Please
Thank you.
enlighten us with your lecture.
Yeah,
Thank you.
yeah. Thank you for inviting me to your session in this nutrition month, and I shall be taking you through, a very brief presentation, just the basics of nutrition in the critical care. We as a dietitian, what we feel. So why do you think nutrition is important? Because we know that these patients are at the population, and a study in our hospital, which is a huge multi specialty hospital, we have found that approximately 40% of our patients that were admitted to the critical care is malnourished. So there is an urgent need to develop a comprehensive nutrition care. So I'll take you through what is this comprehensive nutrition care all about. So as a dietitian, how do we take things forward in the critical care? That is the patients who are very sick, patients not being able to take food through their mouth. So we have to give alternative way of giving nutrition to our patients. So first of all, I would like to emphasize on the MBTR and the IDTR. What does this MBTR mean? MBTR means a multidisciplinary team round or an interdisciplinary team round. So who are the ones who are in this team? Definitely it is the treating physician, the RMO in the ICU, the nurse, the physiotherapist, the medical social worker. All are involved in the MBTR round, because we know that ICU patient population may be at risk, which I had told earlier. So a daily goal planning by the team is very important. So our challenges would be to design a model that would improve the daily goal, that is the daily target for the calories, proteins, and the various micronutrients and the macronutrients, team comprehensiveness, patient and staff satisfaction. And this 24-hour multidisciplinary team will help us to share our responsibilities. The dietitian will do their job, the physiotherapy will do theirs, the nurses will be taught how to feed the patient, and we take the physician who will let us know, or filter our decisions. So self feel more like a part of a team and a clinical decision. So the importance of the dietitian's intervention. So what is the first step? First step is the nutritional assessment. So there has to be an appropriate nutritional assessment, which is going to improve the biochemical and the clinical indications. It is going to improve the patient's disease outcome. It will reduce the complication, and definitely, if all this works out, then it will decrease the length of stay of the patient in the hospital. Apart from that, it is going to be cost saving. So a dietitian doing an early nutritional assessment and appropriate nutritional intervention are considered very essential for the delivery of quality health care. And remember this, all this, when we do, there has to be proper documentation. If there is no documentation, means you have not done anything. So now, what is the nutrition care pathway? The pathway is, first is the nutrition screening, when the when the patient is screened, we come to know if the patient is well nourished or at risk of nutrition or at risk of malnutrition, or the patient may be malnourished. If the patient is at risk or if the patient is malnourished, then the step two is what? There has to be a nutritional assessment. So first is the nutrition screening, followed by the nutritional assessment. Then we have the nutritional plan. Once we plan out what is going to be our daily target or ultimate target of nutrition, we need to monitor it. Now, what is the difference? Like, a question might come to your mind, why I'm talking about screening and assessment. So these are two different things. Screening can be, screening is just the first level, when the patient comes in. Like, a screening is usually done by the nurse, or it can be done by the doctor. So it is the immediate, the minimum measurements, and the least expensive, and information may be concise. But the assessment, it is a little bit longer time. It will go, we have to take in lot of information from the patient or the patient family members. So it takes a longer time, more measurements are done, and it may be expensive, and we have more amount of information. So the information is at depth. So now it is the role of the dietitian to do the assessment of the patient. So there are various nutrition screening and assessment tools that are, that are very commonly used in the hospitals today. The first one is the MUST tool. The MUST tool is the Malnutrition Universal Screening Tool, which is widely used in the UK and the Europe. We have the NRS 2002, that is the Nutritional Risk Screening 2002. This is also used in the European hospitals. Then is the MST tool, that is the Malnutrition Screening Tool, that is used by the Australian hospitals. Then we have the SNAQ, that is the Short Nutritional Assessment Questionnaire, that is in Netherlands. Then we have the SGA, that is the Subjective Global Assessment, which is supposed to be the gold standard for assessment, often preferred for the Asian population. MNA is the mini assessment tool, which we also use in the, when we do some community work. Then we have the Nutric score, that is the Nutric risk in the critical care, that is developed to determine which ICU patient will benefit from aggressive support. So from this slide, we come to know that SGA is the tool that is very commonly used in most of our hospitals. When is nutritional intervention justified? Like, when are we going to feed the patient? Orally fed? Yes, it is good. If the patient nutritional intake is not at par to the nutritional target, then we have to think beyond it to fulfill the target. So this is the feeding algorithm. Once the patient, you do the nutritional assessment of the patient. For the normally nourished patient, there is a normal feeding, that is oral feed, or maybe oral feed along with the SIP feed, that is with the dietary supplements. Normal or a near normal nutritional state, but we know that the patient might deteriorate if he stays in the ICU for a longer period of time. And for the patients who are severe or moderate malnutrition, nutrition support is indicated. It may be oral. If we can give oral nutrition, yes, it is fine. If it is no, if the patient GI tract is working, then we have to think about enteral nutrition, and we give it through the various supplements that are available in the market today. If the patient GI tract is not working, we are not being able to feed orally, or maybe through the NJ tube, that is called the enteral nutrition. There is no other way to give the nutrition except from giving, prescribing some total parenteral nutrition. Total parenteral nutrition, it can, if it is for a short period of time, maybe we can also give some amount of supplemental parenteral nutrition, that is in some time of the day the patient is fed, through the NJ tube, or through the enteral route, and to make up for the deficit, some amount of supplemental parenteral nutrition can be delivered to these patients. So their parenteral nutrition can be delivered through the peripheral line, or even through the central line. And if the patient can be fed enterally, that is enteral support, we can give it through the NJ tube, or it also can be given through the jejunostomy tube, maybe a peg feed or a peg feed. So the nutritional guideline, this is what I had stated earlier. It is a similar slide. So we know that medical nutrition therapy is a term that encompasses the oral nutrition supplement, that is enteral and parenteral, which I had stated earlier. Once the patient is admitted, once the patient is admitted in the critical care, there are two different phases. The first phase, it is called the ebb phase, and the second, it is called the flow phase. The ebb phase comprises the early phase of hemodynamic instability, means the patient is not stable. That is why the patient is in the ICU. While the flow phase includes a subsequent period of metabolic instability and catabolism, which can be less or more prolonged and at a later stage of anabolism. So the two, this PN or EN, that is enteral nutrition or parenteral nutrition, it is also at times termed as artificial nutrition. So the recommendation for the critical care, there are a lot of points. I shall only go through the very important ones. That is, the medical nutrition therapy shall be considered for a patient staying in the ICU more than 48 hours, and a general clinical assessment should be performed. If oral diet shall be preferred over EN and PN, that if the patient is able to eat orally, then the first option is to feed the patient through the normal diet that we give, like rice, dal, vegetable, chicken, fish, soup, salads, etc. But if oral diet is not possible, the next option is EN, and then later on maybe PN. So if the patient, we are not being able to feed the patient within 48 hours, or we know that the patient cannot be fed within 48 hours, then we have to go for enteral nutrition. And in case of contraindications to oral or enteral nutrition, parenteral nutrition within the first 7 days of the patient getting admitted should be considered. And we shall Okay. And to avoid overfeeding, we should look into all the biochemical parameters, because if the patient had not been eating well for the past week or maybe for the past 10 days, then breastfeeding syndrome is a big concern. So we need to look into that. Continuous rather than a bolus feeding should be used. See, this point number 9, it is quite contraindicatory. Some papers say that a continuous feed is good. Some talk about intermittent feeding. Some talk about bolus feeding, right? So you need to look into the consequences of which patient will be benefited by giving a continuous feed rather than a bolus feed. So gastric access should be used as a standard protocol to the enteral nutrition. So we need not put a post pyloric tube for all our patients. Okay, it is only the gastric access should be good enough. And in patient with the gastric feeding intolerance and not getting solved with the prokinetic agents, only then we need to think about a jejunostomy feed. And in patients who are at high risk of aspiration, means lot of aspirate stays back, then a post pyloric, mainly a jejunum feed, can be performed, right? And what is this prokinetic all about? Prokinetics are certain medications which helps in the moving of the food through the intestine. It may be metoclopramide, or it can be also erythromycin. And in critically ill, mechanically ventilated patient, enteral nutrition should be determined by using indirect calorimetry. So this indirect calorimetry is, it might not be available, in all the institutions, but we again go back to the thumb rule of prescribing nutrition to our patients. Hypocaloric feed, that is 70% of the energy should be administered in the early phases of acute illness. Supposing by the calculation we have come to know that the patient requires approximately, say, 1800 kilocalories. You cannot deliver that 1800 kilocalories in day 1 or day 2. You can make it up by the day 4, day 5. Okay. So this is the normal way that we take care of our patients. And especially in the case of burns, we can prescribe some amount of glutamine to our patients, which is also recommended, approximately 0.3 to 0.5 grams per kg per day. During critical illnesses, 1.3 gram of protein is could be enough, and the amount of glucose or carbohydrate administered to the ICU should not exceed 5 mg per gram per minute when we are prescribing these supplements. You can higher good doses or high amount doses of omega-3 enriched enteral nutrition formula can be also delivered through the bolus route, but you need to be very careful while prescribing this glutamine or maybe omega-3 fatty acids, because they may be not contraindicatory, especially in the case of sepsis. Okay, but you can prescribe glutamine for the patients in the neuro ICU. This is just the same recommendation which I had said. Okay, so now nutrition disorders and nutrition related conditions. So what are these nutrition related conditions? This is malnutrition or undernutrition, sarcopenia or frailty, overweight or obesity, micronutrient abnormalities, and refeeding syndrome. So at risk of malnutrition, severe related malnutrition with inflammation, it may be acute or it may be chronic, and this can also be due to the cancer cachexia. Disease related malnutrition without inflammation. And when we talk about malnutrition or undernutrition without diseases, it can be socioeconomic or psychologic related malnutrition and hunger related malnutrition. Now, how are you going to choose the type of nutrition support? See, you have planned out, you have done the assessment. Now you have to choose. Like the first choice is oral nutrition, can swallow safely, and GI tract is functional. Enteral nutrition, fail to respond with oral nutrition alone, GI tract is accessible, and adequate motility and absorptive capacity is there for that particular patient. If that does not work, then the last option is parenteral nutrition. That is when enteral nutrition is not feasible for 7 days, gut not working properly, gut physicality is inaccessible. We cannot reach the gut if the patient is having maybe cancer in the esophagus or say cancer in the stomach. So the gut might not be, there is no way to put in the tube, or the tube feeding is unsafe or unlikely to be effective. Now, what are the assessment, the markers which are not very useful? So in the critical care, you cannot mark a patient to be malnourished by taking the values of the protein markers like albumin, prealbumin, transferrin, binding protein. So these should not be used as an assessment marker, because these parameters may go hayway because the patient is in the critical care and the patient is in stress. Now, what is this tropic or a full EN in ARDS, that is acute respiratory syndrome and acute lung injury? So it is recommended that either tropic or a full nutrition by enteral nutrition is appropriate for patients with respiratory tract distress syndrome or acute lung injury, and those expected to have a duration of mechanical ventilation more than 72 hours. And these categories of feeding have similar patient outcome over the first week of hospitalization. Now, how do you calculate how much of nutrition are you going to give the patient? So this slide is important because it talks about the various guidelines that has been given by the Society of Critical Care Medicine and ASPN, that is American Society for Parenteral and Enteral Nutrition. If your hospital has got an indirect calorimetry, yes, it is fine, because that machine will let you know how much calorie you're supposed to give the patient. But most of the hospitals, we do not have this indirect calorimetry. So in the absence of indirect calorimetry, you need to give around 25 to around 30 kilocalories per kg per day is to be used. For the BMI range of 30 to 50 means the patient is overweight, then we give approximately 11 to 14 kilocalories per kg per weight as per the actual body weight of the patient. And if the BMI is over 50 means the patient is morbidly obese, then the prescription should be 20 to 25 kilocalories per kg per day as per the ideal body weight. I think you see two terms regarding the body weight, that is the actual body weight. Sorry. Yeah, sorry, we have the actual body weight and we have the ideal body weight, right? So these two terms, I think you all are quite common. These are common terms, so you need to abide by this. So since I've talked about the height and the weight of the patient, so now you need the height and weight of the patient. If you do not get the height we can always measure, or we can ask the patient attendant is there, we can take the height and weight from the patient attendant. If the patient attendant is not aware of the patient's height and weight, then we need to measure the patient when the patient is lying in the bed, and the weight can be taken as an estimated weight. And if there is a bed weighing machine in the ICU, then we measure it with the bed weighing machine and we get what is the patient's weight to do all this nutritional calculations. Now regarding the proteins, a waist-based equation, that is 1.2 to 2 grams per kg per day, may be used to monitor the adequacy of the nutrition provision. If the BMI is between 30 and 40, then protein requirement goes up to around 2 grams per day. And if the BMI is above 40, then protein recommendation is 2.5 per kg of the ideal body weight. Now, what is this ideal body weight? There's another term which is also, you will get to know, that is called the adjusted body weight. That is, if we know the know the ideal body weight of the patient, and if the patient is more morbidly obese, then we take into the consideration which is called as the adjusted body weight. So these are the particular formulas that we look into when we do our calculations. So ideal body weight for a male is 50 kgs plus 2.3 kgs for each inch over 5 feet, and for the female it is 45.5 plus 2.5 kgs for every inch over 5 feet. And adjusted body weight is the ideal body weight adjusted by a factor that is usually 0.4 or 40%, from which we come to know which is the adjusted body weight, and certain nutritional requirements are based on taking the adjusted body weight of the patient. So the nutritional care plan, which I had stated earlier, I am going again to the previous note where I talked about functional GI tract. Yes means enteral nutrition, standard nutrient, or maybe a specialty formula. And if the GI tract is not working, then there is parenteral nutrition through the peripheral line or through the central line. Now we had done all our calculations, so now it is the time to select a formula. That is the functional status of the GI tract. Is the patient having any loose motion? Is the patient having anything like not passing stool, etc.? Then the pre-existing condition of the patient, is the patient a diabetic? Does the patient have any renal insufficiency? Then the specific metabolic needs, the specific nutritional needs, physical characteristics of the formula needs to be looked into. That is the osmolarity of the formula that is going to be used, the fiber content, the calorie density. Along with that, we need to look in also to the viscosity of the particular formula. The macronutrient ratio, what is the ratio of the carbohydrate to protein to fats. Okay, these needs to be looked into when we know that the patient has certain pre-existing conditions. The fluid and the electrolyte needs are definitely is the first thing that we need to look into, and things have to be cost effective. We need to look into the patient's medical bills. Okay, so unnecessarily prescribing a very high cost supplement without any benefits should not be considered. So these enteral nutritional formula, they may be the polymeric formula. The polymeric formulas are the commercial formulas and the blenderized formula. The oligomeric formulas are the elemental formula, the semi-elemental formula, and the peptide-based formulas. When we talk about the disease-specific formula, like depending upon the various diseases that the patient might have, maybe diabetic, cancer, or a renal failure patient landing up in the critical care, or maybe, and even some problems like maybe pulmonary problems, right? So these are the disease-specific formula which you can choose from. And regarding the modular formulas, there's a protein modular formula giving only carbohydrates, and certain formulas giving us only fats. Okay. So when we talk about the disease-specific formula, we have the diabetic formula, cancer formula, the kidney failure formula, critical care formula, the pulmonary disease formula, and the hepatic formula. So each of these formulas are laden with the specific nutrient that the patient will be benefited when the patients get the nutrition through these disease-specific formula. For example, a diabetic formula is definitely not going to have sugar in that. Maybe it will be having more amount of fiber into it. A kidney formula there will be a lot of changes in the potassium, sodium, phosphate, right? Then proteins, if the patient is not dialyzed, then the protein requirement is less. For a dialyzed patient, the protein requirement is more. A hepatic formula will definitely be laden with a lot of branched amino acids and maybe MCTs, and a pulmonary formula will be having less amount of carbohydrate, so that there is lesser production of carbon dioxide. So the polymeric formula, the benefits of the formulas, the benefits of a scientific formula, that is the commercial formula, when we compare it with the blenderized feed. Now, this blenderized feeds are the feeds that are made in the kitchen by using rice, dal, milk, chicken, fish, whatever. It is just the normal food that we eat every day that is just blenderized, and then it is strained, and the patient can be fed. So the concerns will be in contamination, because a homemade blenderized formula is likely to get contaminated. Commercial formulas are unlikely to get contaminated. Consistent nutritional delivered. Each feed of these blenderized formulas will not be consistent. At times, it may have more amount of water in it, more amount of a particular nutrient in it, but in a commercial formula, the nutrient delivery is always consistent, because each scoop of that particular formula, every time you prepare it, will be giving similar amount of the nutritional delivery. Instability for the volume sensitive patient, it is very difficult to make a highly dense nutrition, but it is easy when we use a commercial formula. For example, when we have a patient landing up in the critical care, like the patients will be getting a lot of fluids. Okay, so the amount of fluid that is given to a dietitian might be less, maybe just 800 ml, 1000 ml. So with that amount, you cannot make up the nutritional target by using a homemade formula. So in this case, you have to use a commercial enteral nutrition formula. A feeding tube flow, because it might be more dense, the homemade formula, so there are chances of the feeding tube getting clogged, but such complications are not there when we use a commercial formula. And intolerance and immune nutrition, no specific nutrition can be added in the blenderized feed, where we talk about immune functions, and immune functions can be it is available available with the tolerance promoting or other pharmacological nutrient. This polymeric formula, all this time I have talked about the various types of commercial formula. So the first commercial formula, it is the polymeric formula. So these polymeric formulas, they have intact protein, fats, and carbohydrate. Concentration is approximately 1 to 2 kilocalories per ml, and it meets the recommended dietary allowances of the various micronutrients. Most of these polymeric formulas, they have got prebiotics and probiotics, and I think a very large amount, or maybe all of these formulas will be gluten and lactose free. okay, and it usually, it is sufficient amount to meet the 100% nutritional needs of our patient. And recommendation for these formulas are intended for the use among patients with severe malabsorptive disorders. So if a patient has got malabsorption, okay, if the patient has got some GI intolerances, then a polymeric formula, it is not the first choice of formula to be used. So you have to use different formulas which will be easily available by the patients. Next is the oligomeric formulas. These oligomeric formulas may be elemental, hydrolyzed, semi-elemental, or a chemically defined formula. It has the pre-digested nutrient. The amino acid means they are in the form of peptides. It might have glutamine, arginine, it will have glucose polymers, polyunsaturated fatty acids, vitamins, minerals, but the nutrient components and the osmolarity of these formulas, they may be different. The recommendation of the oligomeric formulas are for the patients who have got a compromised digestion or absorption, or if the patient is having irritable bowel disease or irritable bowel syndrome, pancreatic insufficiency, malabsorption, short bowel syndrome, radiation enteritis, early enteral feeding, intolerance to polymeric formula, or there is presence of diarrhea. And if the patient is given tropic feeds are nothing but very small amount of feeds that is given to the patient just for the GI tract to function, so that there is no translocation of the bacteria from the GI tract. The other formula that I would like to emphasize upon, it is the fiber enriched formula. We all talk about fibers these days, okay, and these formulas have got, mostly they have got the prebiotics, the FOS, then inulin, or maybe soy polysaccharides. So these formulas may be beneficial for our patients who has got, a GI intolerance, or for a patient who is diabetic. There is a lot of intolerance prevalence of intolerance, okay, in the critical care. So around 64% of the critically ill patients, they have some amount of GI intolerance, and up to 60% of the enterally fed patients, they experience diarrhea. So on an average, 20% of patients are switched to a peptide-based formula due to the intolerance from a standard formula. So the previous two slides I had shown about the standard formula, that is the polymeric formula, and the second slide before the fiber slide talked about the peptide-based formula. So if there is GI intolerance, then we need to switch to a peptide-based formula. So the disease-specific formula I had already stated earlier. That is the hepatic formula, which may be high in branched amino acid and low in aromatic amino acids. Okay. Yeah, just let me talk a bit on the renal requirement. There are various guidelines which give us recommendations regarding the amount of proteins and the calories that we need to give to our patient, and even of the various electrolytes. For a patient who is non-dialyzed, means the patient is having high amount of creatinine, urea, then the various electrolytes are deranged. So one is the KDOQI guidelines and one is the ESPEN guidelines. As far as calories is concerned, for a person less than 60 years of age, it is 35 kilocalories per kg per day. More than 60 years of age, or if the patient is obese, it is 30 to 35 kilocalories. ESPN also talks similarly the same. Protein for a non-dialyzed patient is 0.6 to 0.75 grams per kg per day, and 50% of these patients need to get the 50% of the proteins should be delivered delivered by the higher biological value protein. Means it will be having all the essential amino acids. But at fast far as the ESPN guidelines are concerned, if the glomerular filtration rate is 25 to 70, then the protein to be delivered is 0.55 to 0.6 per kg per day, per 0.6 grams per kg per day, and 2/3 of the proteins need to be from the. Sorry, I'll just pick up again. Can I call you a bit later, please? Yeah, and if the GFR rate is absolutely low, means the patient is not passing urine. Okay, then the requirements again change. Sorry, yeah, the requirement change to around 0.55 to 0.6 gram, and 2/3 of from higher biological value, and 0.28 per gram per day with essential amino acid, or maybe with essential amino acid along with keto analogs. Phosphorus requirement is 800 to around 1000. ESPN also talks nearly the same, 600 to around 1000 mg per day. There is nothing talked about potassium and sodium in place of by the Kedoki. We need to look into the patient's parameters and then prescribe the potassium and the sodium. But ESPN talks about 1500 to 2000 mg of potassium per day and much less of sodium per day. So this is regarding the patients who are CKD and the patients are dialyzed. So when we know the patient is dialyzed, the nutrition requirement is higher. We will not restrict the protein anymore. We will be giving good amount of protein to our patient. So the selection of the formula again changes. We need to go from a lower protein renal formula to a higher protein renal formula to get to the target for the patient's requirement. For the stage 5 dialysis patient, here I had said that the protein requirement is higher. Let us emphasize only on the protein, that is 1.2 grams per kg per day, and 50% has to be from the higher biological value. ESPN and EB PG also talks nearly the same. So we need to give our patients protein more, right? Today's for the Indian population, protein is 0.8 grams per day, or maybe 1 gram per day per kg body weight. But when the patient is dialyzed, the protein requirement goes up to around 1.2 to around also to 1.4 grams per day. Okay. Now the disease-specific enteral nutrition formulas in the critical care. So when you are in the critical care, you need to choose the supplements with the specific characteristics like intact protein, glutamine, taurine, carnitine, EPA, antioxidants, high calorie density, no arginine supplements. So you cannot prescribe arginine to the critical care patients. And the recommendation of the use is in sepsis, inflammatory, elective surgery, minor trauma, burns, and in pressure ulcer. Pressure ulcer, in other terms, it is known as bed sore. Okay. This is all I had stated, that based on the expert consensus, that it is suggested to use a standard polymeric formula when initiating an enteral nutrition in the critical care. So you need not go for a peptide-based formula while choosing a nutrition formula at the first go for a critical care patient. And for the patients who are obese, right? Based on the experts' consensus, it is suggested that an enteral nutrition formula with low calorie density to be used in the obese patient of the ICU. Now, what could be the problems that a dietitian will face when the dietitian is in the critical care? Number one is diarrhea, nausea, and vomiting. Right? It might have the causes of that is put in the right hand side of the slide. Patient may turn up with constipation. There may be aspiration. There may be hyperglycemia, hypoglycemia, or hypophosphatemia, or hyperkalemia. That is in the case when the patient is having refeeding syndrome. So there is going to be change in the phosphate and the potassium of this patient. Remember, girls, refeeding syndrome is definitely, you have to your minds really open to look into for how many days the patient have not eaten prior to landing up in the critical care. We talk about some, immune modulating formula. So it is suggested that the immune modulating enteral formula should not be used routinely in the medical ICU. That is, the supplements with EPA, DHA, glutamine, and nucleic acid. Consideration for these formulations should be reserved for patients with TBI, that is traumatic brain injury, that is the patient landing up in the neuro ICU, which I had stated earlier, and preoperative patients in the surgical ICU. So a surgical ICU can be benefited with this immune modulating formulas, and also burn patient will definitely be, better, will be, advantage when we use an immune modulating formula. Now, what are the benefits of oral nutrition supplements? This oral nutrition supplements, in other words, it is termed as ONS. ONSs are effective and non-invasive solutions to tackling malnutrition. So national and international reviews of the evidence, for example, NICE, cites that ONS are having significant clinical benefits for malnourished patients when compared to standard care. ONS is what you give certain formulas in between the meals. The patient is not being able to fulfill the nutritional target with the normal breakfast, lunch, and dinner that has been provided to the patients, or at least 300 to 400 kilocalories, around 15 to 20 grams of protein should be prescribed for such patients to meet the nutritional target. So the benefit of these formulas is, which I had stated earlier. If the patient is having some fluid restriction, in the case of for a renal patient, then these supplements can also be mixed with some broth, or maybe custard, or maybe with curd, to fulfill the nutritional requirement. So there are certain proven clinical benefits of using these oral nutrition supplements, which is linked to lower mortality and complication rate for the malnourished patient when compared to the standard rate. So the patients who has been prescribed ONS have been benefited from the control in comparison to the control group. Next is nutrition intervention, that is monitoring and tolerance. So we need to monitor how much the patient had eaten. And remember, your GRV should not be taken into account, right? If the GRV is too much, maybe more than actually it is stated to be more than 500 ml, but here we take it maybe above 300. Okay, we need to speak to the doctor to find out if the interruption of the enteral nutrition is will be benefited or not. Then the feeding status of nil by mouth for the patient, okay, it should be minimized, because when the patient is in the critical care, patient is kept nil by mouth, so there is a lot of feed that is right. So missing of the feed should be captured, and we should be able to catch up for the next feed in the rest of the time that the patient is allowed to get the diet, or the patient is allowed to be fed, because patient may be NPM, that is nil orally, for maybe ultrasound, for maybe a scan, okay, or the patient needs to be for whatever reasons, right? So we need to capture that nil by mouth period. And for those patients which I had said that GRV of less than 500, in the absence of any signs of intolerance, then feed should not be stopped. We should go on feeding the patient. So tolerance to the nutrition may also be measured by the serum glucose concentration, the triglyceride concentration, the arterial, that is the ABG, that's the arterial blood gas status, your liquids, your fluid status, serum electrolyte, and the BUN. This is the slide which talks about that we feed the patient post pyloric if the patients cannot be fed in the stomach. Always remember to put the head end of the patient to around 30 to around 45 degree. Okay, the mouth, there has to be a chlorohexidine mouthwash. and some motility agents may be prescribed to the patient who has got high risk of aspiration. I talked about refeeding syndrome. So who are the patients who are at risk? The risk patients are one or more of the following: when the BMI is less than 16, or unintentional weight loss more than 15% in last three to 6 months, little or no nutritional intake for more than 10 days, low levels of potassium phosphate or magnesium prior to feeding the patient. So when you're starting to feed the patient, we need to look into the potassium, the phosphate, and the magnesium, so that these can be corrected and these do not go lower. Because if we feed the patient in a very high rate in day one, having all these with all these considerations, then we will land up in the patient having refeeding syndrome. So during the refeeding, switch from fat to carbohydrate metabolism. Like in refeeding, what happens? Insulin release stimulated by the glucose load, increased cellular glucose, phosphorus, potassium, and water intake, extracellular depletion of phosphate, potassium, magnesium, and you'll see certain clinical symptoms. So managing refeeding syndrome is to feed the patient with cautious, approximately 10 kilocalories per day for the first two days, 5 kilocalories per kg in extreme cases. So here the dietitian will be able to advise how much amount of calorie the patient should be receiving. And we need to consider of high dose of thiamine and balanced multivitamins, minerals, and mineral supplements. This is a small slide regarding the delivery methods. Like I had talked about this EN. When we talk about EN, the delivery methods are the nasogastric or the orogastric tube, the nasojejunum or a nasojejunal tube, the PEG or the PEJ, especially for a patient whom we know will be continuing on enteral nutrition for more than a month. Then the best thing is to put the patient on a PEG, because the PEG or a PEG, then the patient is going to be more comfortable, right? Types of feeding can be a continuous feed, can be a cyclic feed, can be a bolus, or it can be an intermittent drip feed. So these are the various types of methods how you're going to feed the patient depending upon the patient's condition. So finally, proper documentation of nutrition care plans. All this work, see that the dietitian does all this work for each and every of the patient admitted, especially in the critical care. So all this needs to be documented in the patient's file. So the key issues of documentation, what do we find? First, there is no documentation. The file doesn't have any dietitian notes. Illegible writing, your writing is so bad that no one can read. Current practices of mentioning only volume, rate, duration of calories, protein is required. Both underfeeding and overfeeding has to be shown. For researching patient quality of researching patients' quality of care and developing procedures to address the care inadequacies. And the key suggestions are consistent and easy to read documentation. If it is not documented, it did not happen. All entries should be written in pen or typewritten. Documentation should be complete, clear, concise, objective, legible, and accurate, and all entries should be signed at the end and include the credentials. Okay. So in conclusion, the complexity of the care of the critical care patients requires a coordinated team effort. Practitioners in the ICU should seek opportunities to improve teamwork in their own institution. Team effort should be multidisciplinary. Patient care rounds and a checklist with patient's care goals may improve the patient's outcome and avoid the adverse events. Thank you.
Being such an informative session to us, and it was really helpful for all of us. Okay, so there are several questions about you. Would you like to take a few of them?
Yeah.
Okay.
Thank you, Babita ji. It's a wonderful talk. As I am a physiologist, so I don't have that knowledge in nutrition, but I work with parenteral nutrition.
Okay.
In the sepsis condition, formulation of nano emulsions.
Okay.
So I have also some questions. Let Srija ask first. Okay, thank you.
There are a few questions. There is a question from Shudeep Boron Haiti. How can we give bioactive peptides as nutraceuticals to the patients? I think this is for ICU patients. Okay.
Yeah, I mean these peptide formulas, so they are available in the market.
Okay.
So these are all available today. Various
Okay.
types of peptides,
Commercial biopeptides are
yeah,
used.
yeah.
But we must give them through enteral route, no?
No, not necessarily. They can also be
Parenteral.
given orally. No, parenteral. No, you
No,
cannot give these to them.
not parenteral, but
Yeah,
yes,
enterally,
orally,
yeah,
enteral,
orally or
yes,
through the tube.
or
Okay.
through the tube.
Yeah, yeah.
Yes,
Uh,
yes.
Next, what is the nutritional management in case of coma patient also with gastric inability, and for how long the parenteral feeding be continued?
Parenteral feeding can be continued till the patient is able to take some amount of enteral, at least more than 50%. If the patients can take it through the enteral route or maybe orally, only then the parenteral nutrition can be weaned. See, when the patient is first fed on enteral nutrition, then we go for supplemental enteral nutrition, supplemental parenteral nutrition, that is some amount of maybe around 600-700 kilocalories from PN and rest from the EN, right? That's gradually we increase the EN, right? The enteral nutrition and wean off the parenteral. In the meantime, when the patient's EN is increased, we try to incorporate some amount of oral diet, and when the patient is able to fulfill at least 70% of the oral diet, then that EN supplement can be given as an ONS, that is oral nutrition supplement. Okay, and when the patient is able to take a full diet, the patient can also be weaned off from the oral nutrition supplement. Ultimately, it is meeting the target. For a coma patient with GI intolerances, we need to find out what is the GI intolerances, then choose certain certain products which could be easily absorbable, like the peptide formulas. Apart from that, if the patient is in coma, there is no other way. We cannot feed the patient orally, so it has to be the enteral route if the gut is working, or parenteral if the gut is not there.
Okay. Another one. In case of enteral feeding, what's the rate of getting infections? How can I minimize the chances of getting infections? মানে for the
Enteral nutrition,
nutritionist.
yeah, enteral nutrition, you need to ensure that the shaker in which the feeds are prepared are clean. If the
Okay.
patient is is on a continuous feed, then the feeding bags.
Excuse me, Falguni Bhattacharya, please mute yourself. Okay.
Okay, then the patient's then the patient's the feeding bag needs to be changed every 24 hours. The water that is used to prepare the feed should be should be clean. I mean, should be what is it?
Excuse me, ma'am. I'm interrupting you. Please, Dr. Falguni Bhattacharya, keep mute yourself.
Okay,
Okay, please,
and
ma'am, continue. Huh?
yeah, then we need to ensure that the that the feeds are changed. I mean the openings through which the tubes are inserted, that area needs to be clean. Okay, it needs to be covered and kept. Okay, and all aseptic measurements should be taken so that the feed is not contaminated.
Okay. Actually, Kubali ma'am has some questions he has posted. Do you use probiotics for the ICU patients
Yes, yeah.
like that in after the open heart surgery?
Open heart
Okay.
surgery has got nothing to do, I think, with probiotic, but probiotic is definitely, it can be used. It will definitely do good, and we get probiotics itself, available in the market, and most of these commercial supplements have got probiotic added to it.
Okay.
I read that in place of antibiotics used in the floors and the to disinfect.
Mm.
As disinfectants,
Mm.
probiotics were used in different countries and not in
Okay,
India.
okay, I didn't know
I
that.
read that, so that was the question. Okay,
Okay.
thank you.
Okay. Another one was what diet will be suggested to the patient who is suffering from burn along with CKD?
Oh, that is a very, very tricky question. So burns, we know that we
This is
need,
from Debarchon. Okay.
yeah, we need a lot of proteins, lot of calories for the burn patient. That is to be taken care of, and if the patient is dialyzed, then protein will not be a concern. But the amount of fluid, remember, this is a very, very tricky question. Okay, because for dialysis we need, if the patient is dialyzed, yes, it is fine, but the fluid here is a concern because patients tend to lose a lot of water in burns.
Yes.
Lot of body fluids are lost, so maybe a dialysis is going to help, the continuous dialysis like SLED, or maybe RRT, that's a renal replacement therapy. If that could be given to the burn patient should do well. So the dietitian here really has to look into the case sheets every day.
Another one, which is better to suggest rheumatoid arthritis patient omega-3 fatty acid or omega-6 fatty acid, and why?
See, a lot of studies has been there regarding omega-3, omega-6, because they tend to be anti-inflammatory at times. But you need to get yourself, I mean, your parameters needs to be looked into, okay, when you prescribe these type of supplements. But definitely these immune enhancers and do good.
Okay. Another one from Pubali ma'am. What is your view regarding ketogenic diet?
Ketogenic diet, if you ask me, in my own opinion, ketogenic diet for an epileptic child is really works. Okay, but ketogenic diet for losing weight, I just wonder for how long it can be continued.
Yes,
So
it's a
yeah,
it's a
so
very controversial
yeah,
issue, I
so I
think.
think so I think a ketogenic diet for a short period of time, and then coming up and then going back to a very low calorie diet, I think would be my choice, because I will not prescribe a ketogenic diet. Especially, I will have a very small amount of people going for ketogenic diet. If a patient is diabetic, no, because without carbohydrate, it cannot be. Patient will be taking the
With
medication.
normal people, can normal people go for ketogenic diet for to reduce weight?
Yes, it can, but it cannot be continued for long.
Okay. We don't have any idea. Actually, when I saw your CV, then I thought that we would have asked you to talk on ketogenic diet.
On ketogenic, to really learn of on ketogenic diet, I had done 5 days of 9 to 6 duty, 9 to 6 training program only on ketogenic diet.
Yes.
So it is not very easy just prescribing a high protein diet. Actually, it is not difficult to do.
Is it high protein diet or high fat diet?
High
Fat
fat
diet.
and high protein.
Oh, high fat and high
And
protein,
no carbohydrate.
and
No,
zero carbohydrate.
no. Ketogenic diet, the induction period we can give around 50 grams, but gradually go down to around 10 grams. But for the children, yes, it does good.
Okay. There are two more questions. Would you like to receive them?
Yeah. Two
Okay,
minutes,
okay,
2 minutes left. Two more questions.
okay, okay. Is dietary management will be same in watery diarrhea and bloody diarrhea?
We need to know, first of all, what is the reason, right? What is the reason? Only then we can look into what could be the dietary restrictions, because
Okay.
the cause has to be known.
Yes. I mean, infection is there. Okay. Why soybean is not given to the diabetic patients in some hospitals? This is the most controversial question to us. Ma'am, please tell me about
Why
this.
soybean is not given? Sorry, we give soybean to our
Actually,
patients.
I think the Debarchon has asked that in Peerless Hospital, some of the chief dietitian invited to give the soybean to the diabetic patient. That's why he's asking that.
Okay, maybe I need to look into the literature and then go and then.
Yes,
Yeah.
obviously.
Sorry, I did not know.
Okay.
Thank you very much, Babita ji,
Thank you.
for giving such a wonderful
Thank
and
you.
wonderful lecture.
Thank
Okay,
you. Thank you.
thank you very much.
Thank you. Bye.
Bye. Srija,
Okay.
end up the
Hi.
session.
Hi. Yes. Yes. Now we are going for a short lunch break. We'll meet again at 1:50. I'd like to request all the participants to rejoin at the stated time. Thank you.
द नेक्स्ट इज जितेंद्र. सबको ही मार देते हैं, हम लोग का एक ग्रुप था ना. डन बोलो. दीक्षा ने देख लिया. ग्रेट. ठीक ठाक है ना. हाँ गुड. मेरा फोटो भी देखा. और किसी ने देखा नहीं. अमित तो ऑफ करके रख ही दिया. इन लोग का प्रोग्राम अभी भी चल रहा है. बाबा क्या प्रोग्राम है. लगता है 4 लोग हैं. हाउ नाइस. 5 लोग.
হ্যালো হ্যালো ডক্টর বন্দ্যোপাধ্যায়. হ্যালো সঙ্গমিত্রা. হ্যালো সঙ্গমিত্রা. ওয়েলকাম সঙ্গমিত্রা.
Yeah, but it's
Clock.
yeah. So, what do you think your audience will be?
We will be starting 155 from 155.
No. I'm saying the size of your audience.
Oh, they will join. They will join again. Actually, there was a gap, and so they will join.
5 2. I don't have any problem.
Okay.
So now I'm turning off my camera and my microphone.
Yes.
Please talk.
I will call you. স্যারকে দিয়েছি। হ্যালো, বন্ধ কর। হ্যালো, ওকে। Sanghamitra, can we start?
Uh,
Sanghamitra, can we start?
yes, we can probably. Yes, we can. Is it all right, Valide?
1 minute. Sudeep will introduce you. Okay. Sudeep.
বলে সাউন্ড কম দে।
Sudeep. Sudeep. Is it okay, Sudeep?
Good afternoon and a warm welcome to all of you on this final day of the third international webinar series organized by the Department of Home Science, University of Calcutta on the occasion of Nutrition Month 2022. Moving on to the next lecture session with immense pleasure, I would like to invite our next speaker, Dr. Sanghamitra Bandyopadhyay. We are extremely delighted to have Dr. Bandyopadhyay with us on this platform. Before starting the lecture, I'm going to briefly introduce Dr. Bandyopadhyay. She is a senior principal scientist at CSIR, Indian Institute of Toxicology Research, IITR, Lucknow, and professor at the Academy of Scientific and Innovative Research, ACSIR. She obtained PhD degree in biochemistry from the Calcutta University. Further, following a brief period of research associateship at the CSIR CGCRI, Kolkata, she moved to Harvard University, USA as postdoctoral fellow, where she pursued research in the field of neuroscience. From then on, she continued exploring the field and returning to India, she joined as a scientist and independent investigator at CSIR. Her major research interests include development, neurotoxicology, neurodegeneration, and neuroprotection, focusing on pathogenic mechanism of glial and neuron cell death and damage and their amelioration. She has several peer-reviewed publications, including several in prestigious journals like Journal of Neurochemistry, Journal of Endocrinology, etc. She has been principal investigator for several completed extramural grants from DBT, ICMR, ACRB, Empower, and is currently handling 4 more. Very recently, Dr. Bandyopadhyay has been honored as one amongst the 75 Indian women selected from STEAM, that is science, technology, Engineering, Arts and Mathematics, honored by the Office of the Principal Scientific Advisor, Government of India and the British High Commission. It's our immense pleasure to hear from you on the topic entitled, Is omega-3 fatty acid always neuroprotective? And insight into its divergent effects during development. I would request to all the viewers to mute yourself and enjoy the session. And if you have any questions, please type in the chat box. We'll take them after the session. Welcome, ma'am. The platform is all yours.
Thank you. May I know your name, please? I missed it.
Oh, my name is ma'am Shudeep Haiti.
Okay, thank you, Shudeep. Yeah,
You're welcome.
thank you. Yeah. Yes, so could I start now? I do so.
Yes, ma'am.
Yeah, thank you, Shudeep. Yeah, thank you. So starting with, it's been an honor and a privilege that I have been invited as a speaker to this webinar series, and particularly this invitation coming from Professor Pubali Dhar, who had been slight senior to me during my PhD days. We were under the same mentor at Calcutta University, Professor D.K. Bhattacharya. And though in the list I do not see sir, our very beloved and respected sir, comment for both Pubalidi and myself, nonetheless, I hope sir could be joining, and it's an immense pleasure. And moreover, when you all see to it, or rather seeing the topic, which I would be stating about, that this might be a bit away from what you all are used to, because despite the fact that my PhD, which is 22 years back, had been in the field of the fatty acids, lipids, or somewhere related to nutrition, nonetheless, I've moved away from it for the last 20 years. Still, I made a tenacious effort to link the two, absolutely because of this offer given by my very dear and a person very close to my heart, Pubalidi, your professor or ma'am, Pubali ma'am, which I can never refuse or refute. So going back to the roots, and yes, if you say so, if you all see so, probably keeping or trying to link what I had been doing during my PhD. I tried to link the two with my current research aspect or issue, as Shudeep has said, that it's neurobiology. So that is what you all see to it, that whether I could satisfy you all or by any chance meet to Pubalidi's desire of the day. Thank you. I'm just bringing my slide in. खोल के रखे था उसको.
Sanghamitra, niche share now.
Yeah, I'll do it. Probably I haven't kept my slide open. Is it fine? Pubalidi, is it visible?
Yes, it is visible.
Ma'am, yes, ma'am.
Okay. So yes, as kindly inform me or interrupt if there is any issue with the slide or the voice, any aspect. Okay, kindly do it. Yeah.
Perfect.
So thank you. So it is omega-3 fatty acid always neuroprotective? That is what we knew about. One second. That is what we knew about, or people consider conventionally. Nonetheless, it's probably me, along with the next speaker of the day, if I'm not very wrong, who could also be talking about some aspects other than the neuroprotective aspect of omega-3 fatty acid, where I will, as I said, so an insight into its divergent effects during development, that is brain development. Divergent in the sense, making in a concise manner, that there will be two aspects. First is when omega-3 fatty acid is having a neurodegenerative role during brain development. And the next is, how can I conclude a study without seeing the protection or protective impact of omega-3 fatty acid, which is so well known for its ameliorative prophylactic effects. So yes, ultimately it's going to be neuroprotection. You all must be knowing nonetheless, introducing the brain, the cerebrum or the cerebral cortex, which will cover a major portion of my study, including the hippocampus. These two regions, particularly the hippocampus, is responsible for cognitive function. You'll hear this word or these two words several times in my flow that will go on. And hippocampus, and one of the key functions of, or one of the key parameters of cognitive function is learning memory. So hippocampus, and partially supported by the cerebral cortex, is responsible or play key role in learning memory function. Other than that, these are also the brain regions, but I won't delve on that today. Corpus callosum, which sustains the myelination aspect. Basal ganglia plays a role in emotion. Thalamus, hypothalamus, amygdala, and cerebellum, which is also well studied in my lab, not in relation to this or these studies, which plays a role in coordination. So coming to the brain cells, astrocytes, neurons, capillary, microglia, these are the basic ones which entangle together to sustain the functions of the brain. And again, coming back to the focus of the day, it's going to be astrocytes and the neurons. So astrocytes are the major glial cells of the brain, and it's more than 90% of the glial cells of the brain are astrocytes, and they form a significant support to the brain. Their astrocyte malfunctioning can lead to a extensively damaging and deleterious aspect when it comes to brain functions. So what are the astrocyte functions of astrocytes? First is they provide nutrient to neurons. And obviously you can understand that how important this could be. It regulates the neurotransmitters. It supports the neuron glia communication, or neuron astroglia communication to be more specific. It maintains blood-brain barrier integrity, the BBB, and it regulates neuroinflammation. So this is a photomicrography of immunofluorescence that has been, most of the immunofluorescence images which you all will be seeing, the photomicrography is in my lab itself. Where it is not, you will understand from the pictorial image itself, or I might spell it out. So yes, amongst the green coloration which I've put for the astrocytes, trying to match with the green of our immunofluorescence, these two I have put in a slightly different coloration. The reason is because today's aspect we are going to talk, or today's my talk you might say, is focused mainly on the neuron astroglia communication, or how whether it ultimately leads to neuron astroglia change in communication, and somewhat linked to neuroinflammation in one or two slides. So yes, these are the astrocytes and functions. So what happens to astrocytes? So there are two different conditions that might arise. One is the astrocyte undergoes damage, where the astrocyte size decreases. And more than the size, the prime factor that which defines the functions of astrocytes, the reason why it is marked by the protein, glial fibrillary acidic protein. These fibrils of the astrocytes, they are responsible for maintaining the network with the other cells, and hence any damage to these fibrils that we see in the astrocytes, as we see here, the size of the astrocyte goes down, the fibril number goes down. So in that case, this is a typical situation of astrocyte damage. On the other hand, if there is increased size or inflation of the astrocyte, which is very prominent when you compare the status with a normal astrocyte, where the process number of the fibrils, the length of the processes, the total area of the astrocyte, and the perimeter of the astrocyte has undergone an upregulation. This is a situation of astrogliosis and ultimate inflammation. So when a normal astrocyte undergoes these two conditions where it has been damaged, it could be different aspects. But for my case, at the end or the last a few slides, I'll be showing in relation to what the mandate of our institute is, toxicology, where we've observed this when exposed to toxicants. I'll talk about it later. And astroglossis, again, a situation which I'll be showing very early from now on. So this is it. So any of these two conditions is damaging for the brain and obviously the overall development. So the neuronal, yes. So as I said, so going to neuron and glia interaction, astroglia interaction. So this is how a normal neuron looks. However, we have seen that because of astroglial damage, this is the condition where the damaged neuron, how it looks so. And obviously, this visible damage should be leading to a change in the neurobehavior, which we've seen through cognition impairment or learning memory loss. Now, coming to, yes, I have shown before entering to the concept of omega-3 fatty acid, which is the prime topic to be discussed. So relating it to, because obviously what we do in rats, animals or human cells, that is obviously not our ultimate aspect. So what could be the clinical changes that, or the clinical impact when the astrocyte is damaged? So in fact, you all are very well aware in terms of aging brain, Alzheimer's disease, Parkinson's disease, Huntington disease, etc. These are usually in the situation of astrogliosis. In fact, if you ask me, being in this field for some time and moreover my studies being focused more on the astroglia or astrocyte aspect, whether astrocytes do a change in this manner where reduction of the astrocyte parameters happen, it is relatively less studied. Nonetheless, it is done. I will just show a little bit of this aspect. However, astrogliosis is a very well-known problem, as I've specified the diseases. Now, since we are dealing with the developmental aspects, as I said, my title deals with neurodevelopment. Be it astrogliosis or be it astrocyte damage, 3 or 4 regular diseases, well-known diseases which you all are aware of for children, autism. Astroglial damage is very much, astrocyte damage is very much a key cause of autism, epilepsy, retinal disorders as we see in children. And not only that, this astroglial, whether for a children, obviously they are at a vulnerable stage. Nonetheless, the children also, the recovery is very fast. However, astroglial damage and its link with other damages are relatively irreversible. So ultimately, although Alzheimer's disease is known to be a neuronal damage, which has been seen in adults, you never know whether at the developmental stage the initial problems of it had started or the initial causes in the brain had been happening, where astrocyte damage or astrogliosis could also be key reasons. So this is it. So whether it's a child, though the study we are showing now is for children, nonetheless, it could have long-term effects leading to old age neurodegeneration as well. So yes, entering omega-3 fatty acids. And for this, I presume, and I'm sure, first of all, I have left this field for around 22 years. Second point is that you all are very much aware of this subject, much more than me. So I should not be so audacious to talk about it. It's up to you all to understand this. And today's talk, today's story of mine will basically deal with docosahexaenoic acid, DHA, but the starting point will be omega-3 fatty acid, the capsules which we treat in the animals, where it's a combination of both EPA and DHA. So yes, functions of essential fatty acids in the brain. I specify brain because overall it is known, it is neuroprotective overall, known to be, as I said, conventionally known. Reduction in undesired oxidative stress, regulation of neuroinflammation, and obviously leading to neuronal survival and a regulated neuronal apoptosis, neurodegeneration, the ultimate effect, and learning memory functions, which could be along with other functions. But since today's focus would be learning memory, so all these together may lead to cognition or a regulated neuronal learning memory function. So how did we start with? So as I said, so initially it's going to be only omega-3 fatty acid, and finally in a few slides along with the toxicity of our institute. However, somehow coming to, yes, since I'm talking so much of toxicology, probably you all know, nonetheless, just introducing our institute a bit. Our institute, Indian Institute of Toxicology Research, which was known as ITRC, Industrial Toxicology Research Center before. Nonetheless, in fact, just after my joining, I joined this institute in 2007, as he's already said. So the name was transformed from ITRC to IITR, because currently it is more than 90% dedicated to researchers, which initially it was industrial research mainly. So IITR is one of the 38 CSR institutes, 37 plus 1 it has been now. So, and each CSR institute in our country, obviously in our country, is dedicated to one particular expertise. And I would like to mention, if you all are not aware of, that Lucknow is a much smaller place compared to Kolkata. But here in Lucknow, we have 4 CSR institutes. R is one, IITR, CSR IITR. We have Drug Research Institute, Central Drug Research Institute. We have the Botanical Research Institute, MBRI, and CMAP, which is dedicated to aromatic plants, medicinal and aromatic plants. The last MAP appears. So along with that, there are other 34 institutes throughout our country. And I'm sure you all know in Kolkata, it is CSR, IICB, and CGCRI, the other sister branches of our institute. So bringing back to toxicology, yes, our CSR mandate is whichever mandated institute is there. For example, we have IITR. When it considers CSR funding, you are more or less expected to see toxicology. It could be industrial toxicology. And since I did omega-3 fatty acid, so more or less I'm permitted to do this with CSR funding. Nonetheless, as Shudip has already mentioned, if I'm not telling wrong, Shudip probably. Shudip has already mentioned that, yes?
Shudip is correct.
Thank you, Shudip. So as Shudip has already mentioned that I missed the point, that yes, so that I do have or had several extramural grants. So for all these purposes, we have the authority or the right to use extramural funds to where you could do something other than your toxicology aspect. But here, as you will see somewhere, it may not be toxicology of omega-3 fatty acid. However, throughout you'll be seeing that somewhere I tried to enlighten or highlight that these very well-known conventional prophylactics, in fact, it has been used as therapeutics as well, or doctors also prescribe it, could have a degenerative effect when it comes to brain and when it comes to brain development. So yes, this is the how omega-3 fatty acid in the form of, it was Max-EPA which we had treated, I should have shown it. And it is known that Max-EPA has this is the composition where it has EPA and DHA in it, which you all know nothing less than me. And the treatments we did were, we started as it is development. Now coming to development, the brain development starts very much from gestation. That is when the mother is pregnant from day 1. So we tried to mimic in the rats and we treated the omega-3 fatty acid from gestation day 0. Now, since I'll be talking of astrocytes and neurons, usually the astrocyte maturity starts happening after childbirth, or in this case, after the rat has given birth, that is postnatal day 1. Whereas for neurons, the maturation is more or less has reached to its peak at the embryonic day 16 to 17. The reason why, when we do primary neuronal cultures from the brain of rats or mice, my lab mainly deals with rat and mice. So rats and mice, we do it from the embryonic 16 to 17 day, because as I said, for astrocyte, the peak period starts from postnatal day 1, and for neurons, it's gestation or embryonic day 16 or 17. So yes, we started the omega-3 fatty acid from gestation or embryonic day 1s to the rat mothers, which are known as dams. You all know any when be it embryonic, be it postnatal, when the child or the rat or mice pups are dependent both at the embryonic stage as well as the lactating stage, the mothers are considered as dams. So I might be referring rat dam, the reason why I'm introducing. And so we did the treatment. And yes, again, why the postnatal day 16 is taken. So we did at several phases, postnatal day 0, 1 for the astrocytes. Nonetheless, I'm just focusing on one time point today. And at the postnatal day, which is termed as PND day 16, we did, because this is a situation where the maturity of the rat has reached to its pinnacle. So, maturity of the astrocytes in the rat brain has reached to its pinnacle, particularly in the cortical region, which is the focus. So we isolated the brain tissues and we performed learning memory assessment, as I said so, to understand how omega-3 fatty acid affects whether it is protective or not by assessing the learning memory functions. So what we do is first, very interestingly, this again has a link with toxicology. We assess the level that DHA reaches into the brain when treated with omega-3 fatty acid. Now coming that why I did DHA and why not EPA, because these are the two major components of the capsules that we treat, or the omega-3 fatty acid drugs, or drugs that are available in market. I'm sure probably you all will be knowing that EPA level in the brain is much less compared to DHA. And we also found, I'm not showing the data for EPA, that although the levels of EPA is to DHA in the capsules we treated was 2:1 or 3:2. Nonetheless, when it came to brain levels, the concentration of DHA was significantly higher than that of EPA. So yes, the main focus is on DHA. And moreover, not only that, when it comes to brain functioning, participation of DHA has been found to be more, particularly in the situations where I'm dealing with, that is the cognitive function, etc., etc. So yes, we found that the levels of DHA, V is vehicle. I forgot to introduce it. V is vehicle, which was groundnut oil, and this is omega-3 fatty acid. And from now on, this vehicle or control treated animals, the vehicle treated animals will be referred to as V. I'm sure you all know what V is, what vehicle is. So the basic ingredient on which the omega of any treatment stands, making it more easy, as you'll see later on, when we do arsenic treatment. So we we take arsenic in water. So water here is the vehicle, whereas arsenic is the treatment that we are doing in the cells. So here itself, the vehicle is groundnut oil, because that is the basic constituent close to it on which the omega-3 stands. So this is it. And we did two different concentrations, 60 mg per kg and 120 mg per kg. Coming to the dose or the concentration treated, this is very well standardized. When people work on it, we also did the same. So we found that there was a significantly increase. I didn't show the stars, I missed it. There was a significantly increase. We did it through GCMS in the DHA levels in the brain of the rats when they were exposed to omega-3 fatty acids. Now, it's why we did this. This is not needed to understand that why the DHA level in the brain has become so important. So first of all, it is very important you'll see that when we do cell-based studies to explore mechanisms. And this is again going back to my institute, that I didn't know this. When I first joined the institute, I was very much unaware of the field of toxicology, which several senior scientists of my institute helped me to develop upon. And they told me that, okay, fine, I give treatment in rats and mice in order to mimic what is happening mimic what is happening in human beings. Nonetheless, if I have to explore mechanism, I have to do it on the cells. So be it cell lines, be it primary cells, whatever, I have to do it. So in order to appropriately mimic the condition that is happening in the brain, for example, when I treated omega-3 fatty acid, there is an increase in the DHA for the two different concentration, there is an increase. Now, if I have to see the impact of this DHA level, that how this mechanism of change is happening when I treat to the cells, I have to somehow going back to the mimic, use these concentrations for my cell-based treatments to explore or understand the typical mechanism or to bring back the situation that is happening in the brain as far as possible. So yes, the reason why the relevance of understanding this is very important, which I go back saying again, I learned in the entering the Toxicology Institute, and now I'm very careful about keeping this practice. If not the particular component, we do the analogs as well. For example, we've done with different components, we've done with medicines of diabetes, which for toxicology aspects we've seen. If not the main compound, we've seen the different analogs or derivatives of it, which ultimately reach the brain in my case. Going back to astrocyte, as I said so, and the omega-3 fatty acid treatment and the GFAP, if you all recall, glial fibrillary acidic protein, we carried out Western blotting and we found, interestingly, that upon treatment with omega-3 fatty acid in the rats, there was a significantly increase in the GFAP levels in the cortex. And notably, when I started, because I was brought up with this concept during my research days and further, that omega-3 fatty acid is all the time protective. It was quite a shock for me. This is what research leads to, that it brings new avenues, which has happened, which I very much learned during my, for the last 15 to 16 years when I've been an independent PI itself. I learned also that how much research can bring you to novel fields which you're absolutely unaware of. The same happened for omega-3 fatty acid in our case. It was for me and my students, they came and told me, ma'am, GFAP is going up. So yes, so I did not stop at that. I explored and delved further that why is GFAP going up? And ultimately, is it leading to a damage or a protection? So yes, relating it with the astrocyte morphology, as you've seen earlier, I've said that not only was there an increase in GFAP, validating the aspect, there was features of astrogliosis. We measured it through, we have these different NIH softwares. My students are very expert, which I'm not at all, on having downloading these sites and utilizing and exploiting them for doing all these measurements. And they found that there was an increase in the size of these processes, which together with the other cells sustain the functions of the brain. There was an increase in the number of these fibrils. There was an increase in the area and the perimeter of the astrocytes. So yes, could omega-3 fatty acid always be protective? The question starts harping, and we further explored it. So that is what I showed before was in the animal brain. So these are what we see in the rat cortex, covering hippocampus as well. As we have a paucity of time, I cannot show everything of all the brain regions. Nonetheless, at least the crisp or the cream of it I show. So as I said, that was in vivo based work where the animals were treated. Now I move on to the cells to at least touch upon the mechanism that could lead to this increased GFAP in the rat brain and astrogliosis. So what we did is we cultured primary astrocytes, as astrocyte is my focus, from PND1 when the maturity is more coming to, when the rat brain for astrocytes is undergoing a maturation. We plated the cells isolated from the rat brain. This is from my lab. So the reason why I didn't cite any. You will see from now that wherever I have taken data from other people or pictorial depiction of other people, I've cited. Where you'll find that I have not cited, it is my lab. And in some cases, I'll be mentioning these are papers from my lab. So yes, we plated the rat brain tissues and then on. And obviously, since the brain is composed of several cells, so how do I screen out the astrocytes? So G5 supplement is a component we add to the medium when we aim at doing astrocyte culture, which specifically selects the astrocytes, removing the other cell types. So as we see here, it is more than 95% of the cells are typically astrocytes. And this again is an image from my lab marked by GFAP. And DAPI or hex staining, you'll see later also. These are for the neurons. So I consider this to be a very nice pictographic depiction of the astrocytes. Then what we did was we treated the DHA. Again, going back to the data, if you recall, that these were the levels in the brain that we had observed when the animals or the rats were exposed to omega-3 fatty acid. So we performed a range of those concentrations starting from 0 to 15 micromolar. I'm not getting into the detail because we do have MTT data, etc., for viability. Because somewhere we are ultimately relating it to neurodegeneration or neuronal aspect, that how the astrocytes are affecting the neurons. Nonetheless, coming to a basic aspect, whenever any treatment is done to a particular selected cell type, the first thing we need to see is that treatment, the effect of that treatment on the that particular or your target cell type. However, I'm not going into that aspect. So we did a range from 0 to 15 micromolar, and for these hours, usually for a cell treatment, if it is not very essential, be it cell line, be it cultures, the treatment is confined within 24 hours, 18 to 24 hours, 12 to 18 to 24 hours, because beyond that, the cells, the characteristics or the nature of the cells undergo huge change. So it's better for cell treatment, it is better to confine within this range of time point. And yes, very much corroborating the data that we had observed for the rat brain, we found that in the primary cultured astrocytes as well, when DHA treatment was being given, there was a significantly dose-dependent increase in the level of GFAP. So yes, there is no chance, there is no suspicion or question that stands that could DHA have an effect different from its normal protective effect. And we did a time point analysis as well so that we could come to a selective time point or time points where the other observations or the mechanism could be studied. And we found that yes, till 12-hour treatments, the GFAP levels of the primary astrocytes had gone up significantly, which again had gone down with 18-hour treatment. Now, this is also very interesting that whatever our system, our defense mechanism is so strong in a very crude language, we might say, particularly for children. Yes, if I consider the brain of children, they are the most vulnerable other than the aged people because both of them come to the same status. But the difference between an aging brain and a developing brain is for aging brain, obviously the defense mechanism because of oxidative stress, because DNA damage, of all these factors, their recovery is very poor. Whereas for developing brain in children, the homeostasis is so strong or the defense mechanism is so strong that they recover very soon. And probably mimicking that in the primary cultures, also we found that more or less the GFAP level, and further when we continued just to see to it, in 24 hours, it came back to the status of as in the untreated condition. So yes, for our EXPLODE study, we had selected these 2 time points. Nonetheless, probably if I'm not wrong, I had focused on 1 time point to get to a story. So as we had seen for the rat brain, yes, we see that there is increased process number of process length, astrocytes, area perimeter of the upon treatment with DHA, again supporting the factor of the astrogliosis when the DHA exposure is being given. Now, till now, I have spoken of GFAP, that omega-3 fatty acid or DHA as such in the cells is causing an increase in GFAP, which could be which very strongly suggests astrogliosis, and more or less with the supporting factors, we have shown it. Now, as I said, so yeah, I didn't say, probably I need to say that my lab is very much one of the key labs of our institute who does mechanism. We cannot stop in that omega-3 fatty acid or DHA is doing astrogliosis. Why is it doing so? Who is responsible for these abnormal, I may call it abnormal, or changed or modulated behavior of the astrocytes? So we start with a very prime target of DHA or any other fatty acids, that is fatty acid binding protein. So these omega-3, these fatty acids, be it arachidonic acid, be it DHA, they bind to the FACPs, fatty acid binding protein, which I'll be referring to as FACP, and they go into the brain, and ultimately when they reach the nucleus, these two, they somewhere take the help of peroxisome proliferator activated receptor, which is a nuclear receptor, which ultimately decides its downstream target gene. I'm sure all of you all know what a nuclear receptor is. So they're nuclear receptors, they bind to the gene and then, gene of target or DNA, and finally decide the gene of target, or finally lead to the expression of the gene of target. So with DHA, these two, one is fatty acid binding protein and one is PPR. These two are very much associated molecules or proteins. FAP brings it inside, and then the PPR, one of the key nuclear receptors that causes the modulated expression or expression of the downstream genes and then proteins. So there are several FAPs. Obviously, FAP is not unique for the brain. It is ubiquitously present in our system, in the hepatic cells, in the in the kidney. Kidney. It's in the cardiac cells. It's very much. They do play a very important role. The reason why DHA has a key link with the cardiac functions. So in the brain, if I'm not wrong, FAP3, FAP5, FAP7, these are present. However, though I didn't show the data, FAP7 is very much more abundant compared to FAP3, FAP5, etc. in the brain. And second point is that when we screened our brain tissue, the brain tissue of the rats as well as the primary astrocytes through real-time PCR for the different FAPs that are available or that are present in the human system or the rat system as well, we found that FAP7 was abundantly present in the brain. And moreover, as my story goes on, you'll see that it is the FAP7 which underwent a significant modulation upon omega-3 fatty acid treatment, which then led to modulation in the PPR concept, and finally what we would be seeing. So yes, upon treatment with the omega-3 fatty acid, we found that there was a significantly increased FAP7 level in the brain, particularly in the GFAP expressing astrocytes. So this is that of a vehicle treated brain, where this is the FAP7 expression, which has gone up very much significantly in the omega-3 fatty acid treated rat and the cortex of the brain. You see, validating our earlier data, you see the number of GFAP which are expressing astrocytes, because it relates with astrogliosis, and you see the structure or morphology of the astrocytes. So the level of GFAP has gone up significantly, which very much validates what we did earlier. These are the nuclear hex stains, and when we co-immunolabeled to see what is the expression of this FAP7 in the GFAP expressing astrocytes, I don't think I need to mention that their co-immunolabeling is so much higher. So this is it, that when DHA or when omega-3 fatty acid, which I'm going to mention as DHA for my animal treatments as well, because that is what we had seen in the long run. So DHA treated animals in the brain and showed that there was a significantly increased level of FAP7 in these astrocytes. And this is one of the magnified. We took this portion and magnified this image and found that this is how it looks, this portion, how it looks. So this is overall as the photomicrography of this immunofluorescence overlapped image, and all these images show, which is mentioned in this manner. So yes, omega-3 fatty acid upregulates FAP7 in the astrocytes. Now the question arises, could this, okay, next what we did is, as we went on seeing before, that the in vivo or the data that we observed in the rat brain, we are trying to validate it in the cells. And yes, we found that there was a dose-dependent increase. Like the GFAP, there is a dose-dependent increase in the FAP7 in the primary astrocytes. And again, if you recall the 6-hour, 12-hour data, that also underwent an increase in the primary astrocytes in the DHA-treated cells. So very much the GFAP and the FAP7, if we trust our data, are going hand in hand. So the automatic question that comes, that GFAP comes much later, but the DHA, the first or prime target of it in the brain is FAP7, as we find here. So could the two be related? And what we did is we treated our primary cells with, or we silenced our primary cells using RNAi of FAP-P7 siRNA. So this is how normally the process is done. Again, going back a bit to the protocol, because there are several students or most of you all might be interested in research. So when we do siRNA silencing, so the design is such, it's available in many companies like Sigma, they do provide, or there are several companies we design as well, the siRNAs. So what we do is there's a non-targeting siRNA, if you go and see the biology or the aspect of it, where the FAP-P7 silencing is not there. Nonetheless, other than the FAP-P7 silenced portion, the other regions of the gene are there. So this is, that's a common part for, so that is the common portion of the two are in the form of non-targeted anti-siRNA. So that is what we considered as vehicle in this case, rather than adding too much of sets. The next is when the cells as such were treated with FAP-P7 siRNA, where DHA was not present. The third is where the DHA has been treated in a cell where it is non-targeted siRNA. And the fourth is when the FAP-P7 siRNA, or rather the DHA treatment is done in the FAP-P7 siRNA treated cells. Or rather, I think it's DHA first, followed by FAP-P7 silencing, or vice versa, I might confuse it. So what happens is that in this case, obviously, when there is only FAP-P7 siRNA, the GFAP is, there is no change. But going back to our story, when DHA is done, treated to these cells where FAP-P7 siRNA is not present, there is an increase in the GFAP levels. And then when FAP-P7 is treated, siRNA is treated to these DHA treated cells or co-treated, there is a significant reduction compared to the GFAP level compared to this one. So in fact, I'm not going into it. I should have shown a data where the FAP-P7 silencing was validated. So in a similar manner as we had done for GFAP, we first tested for FAP-P7. I missed the data here. So there we found that upon FAP-P7 silencing in the cells as such, there was a silencing which is happening in the FAP-P7. However, for GFAP, there is no change. When DHA as such is treated to the cells, there is an increase in GFAP, and FAP-P7 silencing could restore the status. So what does it indicate? It's a clear suggestion that some way or the other, the omega-3 fatty acid that had caused an upregulation in the FAP-P7 levels was participating in the increase in GFAP, because when we are silencing the FAP-P7, the GFAP level goes down. Yes, probably I should have shown, but again, I went to the concept of the time scarcity and paucity. We also saw that when this FAP-P7 was treated to the DHA treated cells, there was a reduction in the astrogliosis that was induced upon DHA treatment and all other supporting factors. Now, just touching upon the PPAR, that as I said, so if you recall the pictorial depiction, which I'm again recollecting here, the ligand is DHA. With the help of FAP-P7, it goes inside, binds to the PPR or somehow modulates the PPR, the nuclear receptor PPR, and ultimately causes the change in the genes, which in this case you will see is FAP-P7 and finally GFAP, which could ultimately lead to the changed cell function. I'm just touching upon this aspect also, rather than going to it, that we validated that upon treatment with GFAP, there was an increase in PPR gamma activation in the cells as well as in the rat brain, which we did through, there are different methods. There are several luciferase assay methods, EMSA, CHIP, CoIP, etc., which this journal, okay, this is published paper of Sachin, who's the first author of this paper, one of my PhD students, and then where I've been the corresponding author, obviously. So in this paper, we had shown all the steps, because this is quite a well peer-reviewed journal in the very much conventionally known journal of neurochemistry. And they made us do all possible ways that could be done in order to validate that DHA was truly inducing astrocyte PPR gamma activation in the astrocytes. So we did that. I'm not going into the concept of that here. Nonetheless, what we found, just in order to touch upon the PPR gamma activation concept, that when the primary astrocytes were treated with GW9662, which is an inhibitor of PPR gamma activation. So what we see here, we've already seen that when the cells were treated with DHA, there was an increase in FAP-P7. However, when treated with the inhibitor of PPR gamma activation GW along with DHA, there was a reduction, or rather it was bringing back to the status quo condition. Not only for FAP-P7, ultimately, because of this FAP-P7, for DHA, we know that it has undergone an increase, but whereas when it was treated to the PPR gamma inactivator or inhibitor of PPR gamma activation GW, there is a condition back to the vehicle. So what does it indicate? That yes, DHA or omega-3 fatty acid is inducing an activation of PPR gamma. This PPR gamma activation is then leading to an increased expression and protein level of FAP-P7, which then is leading to an increased GFAP or astrogliosis. So summarizing this aspect, from DHA to GFAP in the brain, this is where we stand, that the DHA leads to an increase in the FAP-P7 level, particularly in the astrocytes. This then leads to PPR gamma activation. Then this causes an increased in FAP-P7 expression through transcription, FAP-P7 protein, which then finally leads to the GFAP increase. As I said, so that astrogliosis has a key link with inflammation, and inflammation is very well marked by the interleukins, the cytokines, the pro-inflammatory cytokines, of which interleukin-1 is one. And yes, notably what we found that when DHA was treated to our primary cells or astrocytes, which we validated later on in the rat brain also, there was an increase in the pro-inflammatory cytokine IL-1 level. When FAP-P7 siRNA was treated to the cells along with the DHA, there was a reduction in the neuroinflammation. And further, for the PPR gamma inhibitor of PPR gamma with the DHA, there was a reduction in the IL-1 alpha. So this indicates, or this very much suggests, that the DHA-induced undesired neuroinflammation that we observe in the growing rat brain, or extrapolating it to children, they could do it. Who are the ones responsible? That yes, could lead to neuroinflammation. First point, that in children exposed to omega-3 fatty acids, even at the doses we used are so-called the therapeutic doses by the doctors, could lead to neuroinflammation. And for this, the upregulated FAP-P7 and the activated PPR gamma and ultimately the GFAP could be responsible. Again, so finally what happens? So we have to come to neurons in order to finish our story. So we found that because of this, I'm not going into the detail of the astrocyte and neuron interaction, which we have done for our paper. So because of this astrocyte and neuron interaction, we have very nice immunofluorescence images of that, where the glial cell is undergoing an inflation or inflated structure, and the neurons are becoming concise and crisp because the glial cell or the astroglia induced damage. And ultimately what it leads to is an increased apoptosis marked by tunnel. Probably you all must be aware of it, that the apoptotic marker is tunnel. It has a big name, which you all can see, that nick end labeling of the nucleus of the cells. So there is an increase in the nicked end labeling of the nucleus in the cells. And as you see here, neuron is a typical marker for neuronal mature neurons. And if you recall what I have said, that all these studies have been done in the postnatal day 16 brain, whereas a neuron reaches its maturation at embryonic 16-17 days. So yes, we have the right to use a mature neuronal marker, and we found that there is a decreased expression of the neuronal marker NUN with an increased apoptosis, and we have to go back to HEXT. And when the three have been merged together, you see that there is such a significant downregulation, such a significant upregulation in the overlapping of apoptotic neurons, which is marked here by the percentage of apoptotic neurons when the animals have been treated with omega-3 fatty acid. So yes, omega-3 fatty acid treatment in rats, which we might extrapolate to children, cause increase in GFAP. Okay, I'll go to this later on. Cause increase in GFAP, which may have been due to the increased FAP-P7, the activated PPR gamma. And yes, I think I've already said that the PPR gamma, in fact, it's such a nice cycle that which I'm missing, that the omega-3 fatty acid is causing an increase in the FAP-P7 in the brain. Omega-3 DHA and FAP-P7 are going to the nucleus, causing an activation of the PPR gamma. And in order to sustain this damaged condition, PPR gamma further causes an increased transcription of FAP-P7. So it's a cycle, which again causes an increase in GFAP. So the cycle goes on and on in case of exposure of children to omega-3 fatty acid, in this case, developing rats. This ultimately could lead to GFAP upregulation, astrogliosis, neuroinflammation, and coming close to neurons, apoptosis, undesired. Apoptosis is also a very regulated and essential event of for all developments, for the developing brain as well. But this is a dysregulated apoptosis, which leads to learning memory loss. So yes, learning memory loss in our lab, we do through tests such as passive avoidance test, Y-maze test, and water maze test. But I'll just give a glimpse of one because it's where both are covered so that all of them need not be shown. So passive avoidance test it's a passive manner of when the rats are avoiding the good and going to the bad, particularly under the brain damage condition. So introducing these two boxes, which are, this is a passive avoidance box, you might call it, which we see or use, or a technique for measuring the learning memory functions for rats and mice. The size is different because mice, I'm sure you all know, are much smaller than the rats. So different sized boxes are there for the rats and mice. So this box that is used, it has a partition where the light chamber is separated from the dark chamber. Rats and mice, these rodents are nocturnal animals, so they have the propensity to go towards a dark chamber instead of staying in the light chamber. So what we see is that at the training period, so first the rats are trained. So during the training phase, it is seen how far the rats are capable of learning in the control case and omega-3 fatty acid treated case. And what we train for is that this is a box, as I said so. This is a light chamber, this is a dark chamber. And the image does not show there is an electric shock here, which is at the bottom of the dark chamber. So rats have a tendency all the time, being nocturnal animals, to go towards the dark chamber. Now, since there is an electric shock here, a normal rat will always try to run away from the electric shock to the light chamber. There is a partition out here, which partition could be closed and opened as according to our necessity to do the study. So when the partition is opened and during the training phase, the rats are allowed to freely move from light to dark chamber. But compared to light, an electric shock is much more a greater event to be avoided, which is a much greater damage, obviously. A light shock is, nobody can tolerate a current or an electric shock. Similarly, it goes for rats. So a normal rat will all the time try to run away from this electric shock chamber to the light chamber, which is more comfortable for it. So during training phase, we train animals for this condition. So that they can acquire that which one is better for them, for both the omega-3 fatty acid treated animals as well as the normal animals. Then this is a test phase where just after 24 hours of training, 48 hours of training, and 72 hours of training, we repeat the same experiment. That is what the training phase that we had, what happens to the test phase, because these are the measurements we are going to be taking, and as it correlates with learning memory. So whatever they had been trained for in the passive avoidance boxes for the rats, are they retaining it? So that is what is measured. And the measurement is detected in the form of transfer latency time in seconds, where how much time the animal or So how much is the retention to move from the light to the dark chamber for the animals in the test case? And we find that the retention is much higher, which is defined by the transfer latency time, is much higher for the control or the vehicle treated rats, and the retention or the learning memory function is much lower in terms of these passive avoidance tests that we do for the DHA treated rats, and the effect is more for the 120 mg per kg or the higher dose of omega-3 fatty acid treated rats compared to the lower dose. So what does it indicate? Through passive avoidance test, which we further validated through the Y-maze test as well, that omega-3 fatty acid treated rats, because we've seen the neuronal apoptosis and ultimate neuronal damage, was leading to neuronal dysfunctions and most importantly, learning memory dysfunction or ultimate cognitive dysfunction for growing children. Summarizing the whole concept of omega-3 fatty acid when treated as such, how the cognitive dysfunction happens. So you will see several factors, PI3 kinase, MKP3. These are a part of Sachin's or our paper in the Journal of Neurochemistry. I'm not going because it's not possible. Neither will you all like, nor will you all remember all the steps. However, it's highlighted it or the marked in red. DHA, yes, there's a preliminary increase in PI3 kinase AKT. And here also, why I would like to point out PI3 kinase AKT, because AKT is also known to be a very prominent and pertinent protective mechanistic pathway. However, we found that despite the fact that DHA causes an increase in PI3 kinase AKT in the astrocytes, there was an ultimate damage to the overall functions and the homeostasis of the brain. So what happens first is DHA, leading to what I've shown here, leading to FAP7 increase. This causes an increase in the PPR gamma activation, and these are the gene sites that we use to do our EMSA, CHIP, etc., luciferase assays. This then leads to an increase in the FAP7 gene expression, which then causes an increase in the FAP7 protein. And as the cycle goes on, this goes on and on, ultimately leading to a GFAP increase, astrogliosis, neuronal damage, which we've shown in the form of neuronal apoptosis, and the resulting or culminating in the learning memory loss, as we've seen for the passive avoidance tests. So this is what omega-3 fatty acid during development does, where we've seen, if I consider my institute, yes, omega-3 fatty acid is having a toxic effect when in children during brain development. And I remember we concluded probably this paper saying that the pediatricians need to be cautious because it's something so close to for the pediatric cases. So need to be cautious when prescribing the omega-3 fatty acids that are regularly given to the mothers, because what I've shown till now is for a child who is in the mother's womb, if I extrapolate, and when dependent upon the mother in terms of lactation. And I would like to add that omega-3 fatty acid is present in, is seen in mother's milk as well. So how it could have a degenerative or a damage to the brain overall, to the astrocytes and overall brain and brain functioning. But it would be very much wrong to say that omega-3 fatty acid is neurodegenerative all the time. Obviously not. Then why will the doctors prescribe? And why will the pharma companies go ahead with it? So is omega-3 fatty acid invariably always neurodegenerative? Absolutely not. That which I've seen correlating with my main mandate of this institute, arsenic exposure. We have done for different. We've done for diabetic drugs as well. But again, I would like to bring a glimpse of my institute's mandate through my data. So what we did is we treated our animals in the manner we've treated omega-3 fatty acid from gestation day 0 or embryonic day, as I've shown earlier. We've done omega-3 fatty acid treatment. We've treated the dams with arsenic. Just I would like to mention, as you see here, these are the different doses of arsenic, which again has a very close connection with our institute, because IITR does or mimics the environmental scenario. In this case, because arsenic is geogenic, difficult to remove, mainly found in groundwater, these are the doses, these are the concentrations of arsenic that is found in the average of groundwater of our country. This is a data which is very recent as well. And though sitting in Lucknow for around 16 years now, I don't think I need to introduce arsenic to you all, because in Malda, a year back also, in Malda of West Bengal, the level of arsenic, which is found to be 0.38 ppm, as the average of our whole country, has been found to be 1000 ppm as well. And you will see that how 10 times of it, or even the 1x, how damaging it is for the brain. I'll talk about it first, and then we go to omega-3, because what I'm saying justifies that while first we treat with omega-3 fatty acid, which is known to be relatively less toxic during the embryonic days compared to arsenic, because when arsenic treatment is started from gestation day 0, it is very difficult for the embryos to survive. So between this GD0 to GD5 for rats, which is, we might extrapolate and calculate it for the human beings, that for this phase, it could be around 1 to 2 months of the pregnancy stage of the woman, that this stage is so much a vulnerable stage that upon arsenic exposure, even at the environmentally relevant doses of our country, the embryos die. So in that case, for that reason, we didn't co-treat with arsenic from gestation day 0, and we started from gestation day 5. The others, with the green is for arsenic and the red for the oral gavage with omega-3 fatty acid, both through oral gavage, and the two were continued together, and the brain isolated as we'd done for the omega-3 fatty acid treatments on postnatal day 16, where the tissue and the cognitive or learning memory functions were assessed. Interestingly, just going to the arsenic concept, what we found was just reverse to what omega-3 fatty acid or DHA had done. There was a down regulation in the GFAP level, and that was also so much dose dependent. 1x is the environmentally relevant dose, 5x is 5 times of it, and 10x of arsenic. The morphology, if you recall, my fourth or fifth slide was astrocyte damage, astrocyte size going small. So unlike omega-3 fatty acid, where the astrocytes was so flared up and inflated, here for arsenic treatment, the astrocyte size is so small, which has been enumerated by increased surface area, parameter, number of processes, etc., which are very significant. So arsenic causes a reduction in GFAP and induces GFAP astrocyte damage by reducing all the essential factors or squeezing the astrocyte and its fibrils to a much smaller number and state. So what do we do? So omega-3 fatty acid is doing just the opposite. Yes, we co-treat the two together, as I've shown in my data, as I've shown in the protocol. So when we see here corroborating or just validating our previous data, yes, arsenic shows a down regulation in the GFAP level. However, when co-treated with DHA or omega-3 fatty acid, there is a significant restoration, because that is what the normal function of omega-3 is. Similarly, for the morphology, we find that arsenic induces a reduction or squeezing of the different parameters, squeezing down. But when treated with DHA or omega-3 fatty acid, it is trying to restore itself in the levels of GFAP and astrocyte morphology. So what we've shown here is for the rats. Again, we cultured primary astrocytes, treated with DHA, then treated with arsenic. And in the cells also, we find there is a reduction in the GFAP level in the primary astrocytes, which again undergoes a restoration when treated with or pre-treated with DHA. Similarly, or again correlating the two, the astrocyte damaged because of the GFAP damage, and with DHA treatment, there is a marked or significant restoration in astrocyte morphology as well. We go back to our FAP-P7 story, and we find that again, that how FAP-P7 is playing a key role in terms of mechanism for defining this GFAP when, or the astrocyte functions, when in case of omega-3 fatty acid treatments. So we found that the FAP-7 level goes down for arsenic, and when treated with DHA or omega-3 fatty acid, there is a significant restoration. And this we've shown in the immunofluorescence image of the sections of the rat brain, where we found that for arsenic, there is a reduction in FAP-7, there is a reduction in GFAP expressing astrocytes, whereas when treated with DHA, there is a restoration in FAP-7, there is somewhat higher, if you recall, so much of astrogliosis, part of it is shown also because it's exceeding. However, when we do the calculation of FAP-7 present in the GFAP, there is somewhat a closeness between the two of them. So FAP-7 reduction happens for arsenic, which is significantly restored for DHA and arsenic together, which we see in the cells as well, cultured cells. So giving a picture that for arsenic, owing to the reduction in FAP-7, there is a reduction in GFAP, there is a reduction in the astroglial morphology, which when pre-treated with omega-3 fatty acid or DHA in this situation is having a protective effect because of the recovery and the restoration. Ultimately, does it have any effect on the neurons? Yes, it does. So the way as omega-3 fatty acid had caused an increase in the apoptosis or undesired apoptosis of the neurons that are associated with the astrocytes. It happens for arsenic as well, if not more. But when omega-3 fatty acid is pre-treated, it causes a reduction in the apoptosis. So here it is, the astrocyte apoptotic index go up when arsenic is treated. But because the DHA has, as such, may be degenerative, nonetheless, probably because of its capability of upregulating GFAP, which it does in this case, leading to a restoration or reduction in the apoptosis, as we've seen here from this. So ultimately transpiring into the learning memory function, we saw that omega as such caused learning memory dysfunction because of neuronal damage. However, arsenic as well does so. And when co-treated with DHA or pre-treated with DHA, there is a marked recovery in the transfer latency time, which ultimately defines the learning memory. So omega-3 fatty acid induces recovery in the arsenic-induced learning memory loss that we observe here. So hence, summarizing, I'm not going into the typical step-by-step summary. I'm just showing that these are the omega-3 fatty acid capsules that are prescribed when as such in a developing brain, as such if exposed, it could be neurodegenerative, where FAP-7, PPR gamma, GFAP increase, astrogliosis, inflammation, ultimate neuronal damage, and cognitive dysfunction together is the key term neurodegenerative, whereas it could be neuroprotective in a brain. You see here how flustered this child looks, that in our case, it was arsenic which was causing this damage or this look of exasperation and fluster in the child, where omega-3 fatty acid, because of its treatment, could have an ameliorative and protective role. Thank you. So please, it's open to questions. I don't know whether I could make you all understand anything.
Many questions.
Okay.
Many questions.
Okay, so should I go to the slide, remove the...
No.
Okay. Yes, Pupalidi, I can... Hey, what happened? I don't know. Something is happening.
Actually, the whole pillar, you shook our nutrition, pillar of nutrition.
Okay. So my slides are still visible, Pupalidi?
No. Yes.
No.
Yes.
1 minute. I think I'm moved out of slideshow. I don't know. Can I call my student? Because I'm very much an amateur on all this. My student... Asmita?
Yes.
They are all there. Please, I don't know. I made
It's okay.
I mean, the slides are visible.
Yes, slides are visible now? Okay, fine. Yeah. Along with me. Yeah. Yes, Pupalidi and whoever I'm open to. And Pupalidi, just one thing, one note I want to add. My students, my students who had done omega-3 fatty acid are currently not here. They've all finished their thesis and left. nonetheless, I have others as well. So if I fail to satisfy any of their points, I hope you all will give them the chance to answer as well. So, and one more point is that though this should be said by Pubalidi, I think it's better to raise hands one by one. Am I right, Pubalidi?
Yes, yes.
Okay, thank you. I'm open now to questions.
Let me talk first.
Sure, sure.
Sudeep,
My pleasure.
let me talk first.
Yes, ma'am. Oh, yes, ma'am.
Actually, what you have told is in the first part, you have told that it is it induces apoptosis, and the degenerative process, it induces that degenerative process. It is not neuroprotective.
No.
In the next part, you said that from the different toxicological components, when they are given to the animals, and then they are the DHA is given, then it is giving protection. Am I right?
Absolutely. Only Pubalidi, I would like to correct.
Yes.
It is a pre-treatment with omega-3 fatty.
Okay, pre-treatment. As we know that I don't have any I haven't worked with omega-3 in neuronal system, but I have read many things about cardiovascular system. So DHA is converted to lipid mediators. Now, from the nutritional point of view, we don't talk about DHA and DPA, but we talk more about lipid mediators that are synthesized from DHA. Very important lipid mediators that are synthesized from DHA, that is 17S hydroxy DHA, and there are other two, and they produce protectins in cardiovascular system. So the balance between DHA and omega-6, that is very important, and in inflammation also, these protectins, they reduce the inflammation. In the inflammatory process, I have read those articles. I haven't worked with those articles. I haven't worked with DHA at that molecular level, but okay.
Pubalidi, I would like to interrupt. I missed your last two sentences.
I haven't worked with DHA at the molecular level, but what I have read is that in the cardiovascular system, these DHA, they produce some lipid mediators. There are 3 molecules that produce protectins, and those protectins help in balancing the inflammation in the cardiovascular system. So myriticin, I may be wrong, the pronunciation may be wrong, and protectins, they are very important to reduce the inflammation, and they are mainly synthesized from omega-3, that is EPA and DHA, and D1, D2, D3. So these are all the molecules that are produced in cardiovascular system. But I don't know why it is in the neuronal system, these DHA, they are metabolized. I think what are the metabolic products that are produced from those DHA in the neuronal system? Have you got any product that are metabolized products from DHA?
I think what you've mentioned in the cardiovascular system, in the brain as well, the products are the same. So they go hand in hand, because if you consider the cardio and the neuronal system, they have significant overlap in their physiology. The reason why all these the studies of all these electrophysiology is so, the two are so well connected. So yes, in terms of physiology, I might be, I mean, there could be other molecules as well. I'm not very specific of them. Nonetheless, there is a significant overlap between the two. So yes, the way you're proceeding, your question comes in the right direction. Yes,
that is the inflammation. From the point of inflammation, the balance is between omega-6 and omega-3, that is the mediators that are produced from omega-6 and omega-3, that are very important. The level of those products is important in reducing the chronic inflammation. The inflammation becomes worst condition when it is chronic inflammation. So we must stop that chronic inflammation. Inflammation may take place, but it may reduce. But in case of aging also, the inflammation, there is a low level of inflammation in the neuronal system, and apoptosis takes place in the neuronal system. In those, whether you have any data in case of aging, where inflammation, brain inflammation is very important, that occurs in aging. Have you got any such data? These are experimental data you have shown, and they are wonderful data, and you have shook my entire concept of DHA.
So yes, I do get your question. Point one, as Shrudeep had introduced, that one of my major fields is neurodegeneration. So why I specifically, and the word neurodegeneration, it is more relevant for aging disorders. Because for developmental biology, the word degeneration is a little less applicable. Nonetheless, I had the audacity to talk about it, because ultimately we are seeing neuronal damage, be it at a developmental stage or at an adulthood. Coming to your last question, for neurodegeneration, Pubalidi, I might correct you a bit. It is not inflammation specifically that undergoes a downregulation. Now, again, IL-1 is such an essential molecule that without IL-1, alpha, beta, or TNF-alpha, IL-6, the brain cannot survive. And going back to what I had done, because I have worked on Alzheimer's disease models, and just plain and simple, without going into the downstream molecules of the protectins of DHA, what happens in a normal developing brain, that there is a time-dependent change in the inflammation. And as you have very correctly specified, that chronic exposure to inflammation causes neurodegeneration, but that is when the inflammation goes up. On the other hand, even for AD cases, a short-term exposure, what we term as acute exposure to the inflammatory molecules, has been found to be protective. So it is a balance between these inflammatory molecules that terms a disease as neurodegenerative, yes or no. So the number of cytokines, pro-inflammatory cytokines, the generation of the anti-inflammatory cytokines, the balance between the two decides whether it is AD is happening. One of the factors, the other factor being oxidative stress, which I'll come to later on, because these two are the prime reasons which regulate and dysregulate our total system, particularly when it comes to neurons and the brain, astrocyte, etc. So yes, so a level of the inflammation, very much as it has done for developing rat brain and children, it is much more relevant for the aging brain, because as I said, so the homeostasis of the aging brain goes to a poorer level, much poorer level compared to the child who are born. This is point one. Yes, balance in the inflammation we have observed very well with the time points or the time of exposure of these inflammatory molecules that have played a role in Alzheimer's disease. That is what I focused upon mainly in our models. And secondly, coming to your previous question regarding the protectins, if you ask me, no, I have not seen the protectins. And although they are responsible for regulating or dysregulating inflammation, since I have mentioned another term as well, oxidative stress, the levels of these or their status, the saturation, unsaturations, or etc., of these protectants or downstream molecules of DHA are very much also in a cyclic manner governed by oxidative stress as well as inflammation. So it's not that typically they are leading to inflammation. Inflammation also guides them. So these mechanistic cycles happening between the downstream target molecules and the inflammatory molecules, oxidative parameters, and other supportive parameters in the brain that lead to their status as well. So could I explain something, Pubalidi?
Yes, but I think my suggestion is try to measure those mediators, that is pro-resolving mediators in that system, if you can, because your institute is a large institute and you have enough money, so you can go for those metabolic products that are synthesized, whether they specifically have any specific role in your what you are working on. I think you may do that. It's my suggestion.
Should I answer this?
Yes.
The reason is that a very well suggestion, which I do take from the core of my heart. Thank you, Pubalidi. Actually, if I consider, as I said, so when we do I'll do it. I'll obviously do it because it's such a nice suggestion. Nonetheless, again, correlating with our institute, in situations where we do not find downstream derivatives because what is omega-3 fatty acid capsule composed of? It has EPA and DHA are major components. So when it comes to bringing close to the mandate of our institute, so yes, we see omega-3 fatty acid and then we check the levels of DHA in the brain and we go ahead with it. We go for the downstream targets, as you're saying, the resolvins and the protectants. That is when we do not find that target, we do not find that particular molecule, in this case DHA or EPA in the brain. Even arsenic may have many downstream forms, but since we also, upon exposure to arsenic, we typically find arsenic in the brain when we do the AFS, etc., etc. So in that case, as per our mandate, we are supposed to see the typical effect of arsenic and its mechanism. Similarly for DHA, we are exposing to DHA, we are finding DHA in the brain, we are seeing the downstream, we are seeing the mechanisms. We are not delving into the resolvins and the protectants. But however, coming to, yes, my money, institute's money, I mean the CSR funded money, GAP, the grant in aid projects, as well as the infrastructure of the institute, we do have a very good analytical chemistry department with very strong young scientists and many new equipments being brought. So I could see, but if you ask me, that is not typically the mandate of our institute. The mandate of our institute in this case stops with DHA or with arsenic and its mechanism. For my curiosity, because I get it from you, I could be seeing it.
Thank you. There are other questions. Shudip will give you the questions.
Sure.
Yes, thank you so much, ma'am, for such wonderful session. I would like to take a few questions from the viewers. One is from Devarshan, saying, in case of neural diseases, one of renowned name is Parkinson's disease, without using omega-3 fatty acid resources, how will we manage this disease where dopamine is playing the crucial role?
Yeah, there are dopaminergic drugs now. Probably there are dopaminergic drugs which are L-Dopa and all these are available where the doctors, the clinicians do give. Omega-3 fatty acid is not a therapy typically. The doctors also add to it in a prophylactic manner. They cannot, if I'm not very wrong, Pubalidi will be knowing better than me that it cannot be considered as a therapy. It's something which is a protective aspect. And yes, there are nowadays rather for Parkinson's, it's better than Alzheimer's because in Alzheimer's, it is absolutely a system, the symptomatic drugs that are available, some anti-inflammatory drugs which are available for it's typically targeted to the pathology of the Alzheimer's is not. But in Parkinson's, there are, I think, L-dopa analogs, etc., are being used nowadays to target the dopaminergic neurons. Yes.
Okay, ma'am. Okay, ma'am. The next question is from Srija. She's asking, what should be the GRAS value of omega-3 fatty acid?
That's I knew when I was talking about it. Since again coming to it, it is a aspect which is being explored. We have the neighboring CDRI, Drug Research Institute, and they just produce the drugs, or they just tell this is the drug that is available. We could form this drug. After that, there are so many years of different phases of clinical trials. I'll just give an example, because when I was in US, I had been working on Alzheimer's disease. And obviously, as you've seen, I had the opportunity of working with a very good lab. And there, which is my credit, I can say that I alone did a screening of 110,000 drugs. We had a laboratory for a drug-induced neurodegeneration, to identify drugs for neurodegeneration. So I did the high throughput screening. And before I left from there, ultimately from the 110,000 drugs, through the screening process, we screened down, and then we came to 12 drugs. Okay. This was before the year 2006. So after leaving that, it's been 2006 to 2012. It's been 16 years now. I think of those 12 drugs, 2 are there which are being currently carried on and performed and given for clinical trials. So clinical trials of drug, it could be taking 7-8 years. It could be taking 70 years as well. So first of all, I'm not a drug person. So I'm not supposed to be specifying the dose of the drugs. And if I consider CDRI, the Drug Research Institute, they also cannot be stating until and unless thorough clinical studies are done in order to come to a particular concentration. However, yes, as I said, so probably because Indians and specifically sitting in West Bengal, you all are so exposed to arsenic. So more or less probably the prescribed drug of until and unless someone is exposed to a very clean condition where there are no exposures, no toxicity, probably something less than 60 mg per kg could be. And if a child is kept in an absolute isolated condition where there is no arsenic exposure, then in that case, obviously much lesser than the 60 mg per kg. So that is what it is. Coming to a clinical dose is typically not the domain of us researchers, and that also involves many phases. However, since Srija has asked from me, I would say, yes, we could vary somewhere between 20 mg per kg, 30 mg per kg.
Okay, ma'am. Another question from her is that the people who are given omega-3 fatty acids for treating chronic diseases may suffer from neurodegeneration in future?
Yes, as I've shown. Because the children who are undergoing, or I haven't done on clinical studies, if I consider rats, extrapolating it to clinical or human cases, who have undergone the astrocyte damage and ultimate neurodegeneration, despite the fact that for children the recovery is good, nonetheless they are highly predisposed. So you never know whether Alzheimer's disease at the end, probably this omega-3 fatty acid, this is where the divergence or the dual role come, that this omega-3 fatty acid, which could have acted as a degenerative incorporator at the early stages, is acting as a protective one at the later stages. So yes, in one single sentence, because of this predisposition or imprinting from childhood to adulthood, it could be the reason as well. That is what our data show, my lab data show.
Okay, ma'am. Another question is from her, that are the FFBT7 increased in presence of omega-3 fatty acids?
Yes, I've shown. That is the main function. It's not a big what.
Yes.
FAP7 goes up, but it depends. As I said, so liver targets FAP5, yeah, it goes up in the brain. Yeah.
So is it only for omega-3 fatty acids? Can the other fatty acids interfere with the pathways?
No. Even EPA shows it depends. The different fatty acids have different binding proteins with them. EPA also undergoes all of them. ALA, all of them undergo. they have their specific FAP7, binding aspects. Yeah.
Okay. Is there any relationship between different fatty acids?
In terms of neuronal aspects.
No, can this damaging mechanism be protected using other fatty acids?
I'm sorry to say, I haven't studied it. For EPA, it is not. Interestingly, since you raised issue of another other fatty acids, I'll just go back to EPA, because this omega-3 fatty acid, we are doing a co-treat. The capsules that are available are EPA and DHA together. So the reason why I went ahead with DHA, number one, as I said, so the level of DHA goes up significantly compared to EPA. And again, when we treated our cells with EPA only rather than DHA, the effect we saw for DHA in terms of GFAP increase, etc., was not that, we did not see such significant effect for EPA. So again, the question stays that whether, just I'm thinking, I've never thought of this before, that whether the percentage or the composition of the capsules could be changed so that it is more. Actually, the problem with EPA is that its level in the brain is not that high, because it undergoes beta oxidation and the incorporation into the phospholipids. All these factors are much less for EPA. The reason why it cannot go up, but whatever EPA we had obtained in the rat brain, when we mimicked it and treated with the cells, the damage that we had observed for DHA was not so prominent. But however, when you treat omega-3 fatty acids, its upregulation, the upregulation of DHA is much more, its functional aspects, its functioning or its performance is much more in the brain compared to the EPA or other fatty acids. But I do not know whether co-treatment with any other, that ALA, linolenic acid, could have a protective role. I'm unaware of it. Until and unless I do it. Nonetheless, since this is also Srija's question.
Yes, ma'am. Yes.
So since Srija has suggested, I could give a thought to this. Yes, the way Pubalidi's was, that the upstream molecule, Srija talks about upstream mainly, Pubalidi talks about the downstream molecules of DHA.
Downstream.
Yeah, so both could be, I could see to it positively. Yes.
Okay. Anyone have any questions? I guess no. So thank you, ma'am, once again. We're very grateful to you for making time for us with your video.
Okay, I'll try to summarize the feedback from Pubbalidi, because it was
now I'd like to request. Yeah. Okay, now I'd like to request Professor Pubalidhar ma'am to take over.
Thank you very much, Shangomitra, for a wonderful session and brainstorming session. And Srija is talking about many ideas, because actually we have esterified lutein with EPA.
Mm-hmm.
EPA DHA, and in that product, that fatty acid is protected by lutein, and lutein itself is oxidized, and it is a very good drug for eye in glaucoma, that is degeneration of the retina.
Right.
And there in the eye, the drugs, the eye drops, they use lutein. But lutein is very easily oxidized. So we esterified that lutein with long chain polyunsaturated fatty acids like EPA DHA, which stabilized, both EPA DHA is stabilized and lutein is also stabilized. So that is a very good antioxidant, but we haven't done any in vivo experiments. So from now on, I will think of this part of FDHA, this idea of yours, that is whether it is neuroprotective or neurodegenerative. That is a very important question, and we must think of it another time. So thank you very much, Shangomitra.
Pubalidi, I would like to interrupt. Point one is that I would like to get the answer from you. I was very skeptical. My students were one of my students, I took a lot of help from her, I should acknowledge, Ashmita Garg. So she helped me in finishing my slides. So both of us were quite skeptical whether to what extent I could fit currently into the nutrition scenario. So
No, you are just
okay, fine.
over fit, sir.
Then,
so sir have joined us, and Muhadi is also in our list. So they have heard your lecture, and I think sir will tell about your lecture over phone. Thank you very much.
No, 1 minute, Pubali, they're not yet over if your time permits.
No, time is there. Enough time is there.
So because Srija has so many questions, it's not only Srija, whoever wants to contact me for any purposes in relation to this or other than this as well, you are free to email me. Number one, if anybody needs any, for example, if I take Srija's case, if she wants to come and work in my lab also, probably we could arrange for it. I have a very helpful bunch of students. So since this so-called virtual collaboration has started, probably, though they require some norms from our institute, but with Pubali in between, we could do that as well. But however, currently emails and email interactions, it's my pleasure to do so.
Thank you. Thank you.
Thank you, Pubali.
Welcome, Dr. Hosanna Rodrigues. Thank you very much for this change, time change, and you have accepted our invitation in this webinar, international webinar. Thank you very much. You have helped me a lot. Thank you very much. So we will start and let my student they introduce you, and there is a small lecture before your lecture. Can we do that?
Yes. Hi.
Yes. Thank you.
Good morning. Good afternoon.
Yes, yours. Good morning, and here we are in evening. Okay. Thank you very much. Abhedi, are you there? Abhedi? Abhedi? Abhedi's that internet has collapsed, so let us start. And Shachita, please introduce our next speaker.
Moving on to the next and final lecture session for today. With immense pleasure, I would like to invite our next speaker, Professor Dr. Hosanna Gomes Rodrigues. Ma'am, we are extremely fortunate to have you with us. Dr. Hosanna Gomes Rodrigues has several accolades and accomplishments that are quite impossible to sum up in a brief time, yet I'm trying my best. Professor Hosanna Gomes Rodrigues studied nutrition at the State University of Sao Paulo, Brazil in 2004. Her PhD was in human physiology at the University of Sao Paulo, Brazil, working with fatty acids and immunity. At this time, she did a brief internship at the University of Southampton, UK, in the laboratory of Professor Philip Calder, working with fatty acid incorporations into biological samples. In 2014, she established a laboratory at the University of Campinas, Brazil, with focuses on understanding the effects of fatty acid on skin repair. A group is interested in the cellular and molecular mechanisms involved in inflammations and extracellular matrix formation during wound healing. Delayed wound healing is a devastating complications of diabetes, and supplementations with omega-3 fatty acids are an appealing strategy for these patients. It's our immense pleasure to hear Dr. Rosanna Gomes Rodriguez on this topic entitled The Impact of Oral Administrations of Eicosapentaenoic Acid-Rich Oil on Wound Healing in Diabetic Mice. Welcome, ma'am. We are extremely happy to have you. The platform is eagerly waiting for you. It's all yours.
Okay, thank you. Thank you, everybody. Thanks for the invitation. It's a great pleasure to share my work with you. I'm very happy. I'm just so sorry because I wasn't expecting to do this at this time. So I'm at home. It was impossible to reach the university now. But I will share my screen. Can you see? Can you see my presentation? Because now I cannot see you. Oh, so sorry, my dog. Can you see? Yes. So okay.
Yes, ma'am. It's all
okay.
visible now.
Okay. Yes. So today I will talk about our work. This is a study of my PhD student entitled Fish Oil Supplementation Activates PPAR Gamma and Delays Skin Wound Healing in STZ-Induced Diabetic Mice. So I'm a professor at the School of Applied Science, University of Campinas, São Paulo, Brazil. This is my email, so feel free to send me a message if you want to understand some other aspects that I will not discuss today. So as you know, skin is our largest organ in the body, and it is essential for our surveillance, and it protects us against external hazards. It's a very important immunological tissue. It was described recently. And considering that the integrity of the skin is essential for our surveillance, the wound healing process is a process that is essential for our life. So wound healing process is actually divided into main phase, so the inflammatory phase, the proliferative phase, and the remodeling phase. These phases are characterized by the infiltration of different cell types and the action of these cell types to restore the integrity of the tissue. So when we have a skin wound or when we have a disruption in the skin integrity, mast cells and neutrophils, they arrive to the inflamed area and they start to produce inflammatory mediators such as cytokines, reactive oxygen species to clean the area, because usually we will have some pathogens in this wound, and to orchestrate the arrival of other cell types that will reconstruct the tissue. The next phase, the proliferative phase, is characterized by the arrival of fibroblasts. That's the main cell population involved in skin tissue. So fibroblasts and macrophages. These cells, macrophages, will orchestrate the formation of new vessels. Here I represent as the angiogenesis. Also, the macrophages will differentiate into different polarization, and they will also orchestrate the differentiation of fibroblasts into myofibroblasts, and these cells will contract the wound edge to close the wound. These myofibroblasts and fibroblasts, they will also induce the formation of collagen, the production of collagen. This collagen is important for the construction, the construction of the extracellular matrix that will be the basement for the construction of the new vessels. After this proliferative phase, we have the remodeling phase. This is the last phase of wound tissue, wound repair, and this phase is characterized by the synthesis and degradation of collagen, because we need the same direction of the collagen fibers that we have before the wound induction. So although we divide the wound repair in 3 phases, all these phases are concomitant and interconnected. So if we have acceleration or a delay in any of these phases, we can accelerate or delay the entire process. So the wound care is a multidisciplinary approach, so it needs a multidisciplinary approach. And among all the disciplines that are involved in wound care, nutrition has a very important role, because we know that we have a lot of nutrients that are immunomodulatory. So these nutrients, they can modify the immune response, and as I showed, immune response is quite important for the wound healing. Among the immune nutrients, omega-3 fatty acids have been studied a long time ago, because they induce different immune response depending on the disease studied. So as you know, I'm sure, omega-3 fatty acids, the main omega-3 fatty acids that we find in our diet are EPA, eicosapentaenoic acid, and DHA, docosahexaenoic acid. These fatty acids are found in fish or fish oil, and in 2009, we described that these fatty acids, although they are from the same family, the omega-3 family, they have different functions in different cells or in different disease. So it's important to point which omega-3 fatty acids we are talking about, not saying all omega-3 fatty acids, because they are not the same, and they do not have the same role in the cells. So considering that omega-3 fatty acids affect inflammation, and inflammation is part of the tissue repair, we decide to study the effects of omega-3 fatty acids on wound healing. So in 2019, we published this paper, and we demonstrated that mice that were supplemented with EPA-rich oil, they had a delay in the wound closure, as you can see here, and as you can see in the picture. And this delay was related with the increase in M2 macrophages in the wound tissue, as well as in the increase in IL-10 production in the wound tissue in this mice supplemented with EPA-rich oil. We also observed that these mice supplemented with EPA-rich oil, they impaired the collagen organization after the closure of the wound. So the last phase of the wound repair was also impaired in these mice. So considering this increase in IL-10 production, we evaluate the essentiality of this IL-10 to the effects of EPA. So to prove this, we used IL-10 knockout mice and IL-10 knockout mice supplemented with EPA-rich oil, and we observed that the deleterious effect of EPA was abolished when we don't have IL-10. So we did not see any difference in the wound area, and we also see improvement in the collagen organization when we compare these mice, showing that IL-10 was essential for the deleterious effect of EPA-rich oil. So we demonstrate in this paper that oral administration of EPA-rich oil delays wound healing due to anti-inflammatory effects, and considering that the anti-inflammatory effects were deleterious, we thought, okay, so EPA could improve the skin repair in pro-inflammatory condition, such as during diabetes. So we tested this hypothesis. We consider that wound healing is a conserved process, but there are some pathological conditions that hinder the proper evolution of the wound healing, such as diabetes. So high diabetes, people who are living with diabetes, they don't heal. We know that there's a disruption in the wound healing process during diabetes, and there are some hypotheses why this occurs, and one of them is that there's a loss of control in the inflammatory phase of wound healing during diabetes, because we have the infiltration of a huge amount of neutrophils and macrophages, and these cells start to produce a high concentration of cytokines that will damage the tissue instead of heal the wound. So with this loss of control of inflammation, the formation of new vessels are also uncontrolled. So the entire process didn't go in the same in the direction to close the wound. So we know that the diabetic wound has problems with inflammatory cells functions, angiogenesis, that is the formation of new vessels, the proliferation and differentiation of fibroblasts into myofibroblasts, and there's expectative that one person that lives with diabetes lost his suffers lower limb amputation due to diabetes in every 30 seconds. So, as we know, lower limb amputation is a very difficult process, because we cannot reverse the loss, and it causes social, economic, and psychological problems. So it's important to avoid this action. So to understand if omega-3 fatty acids could help the wound healing process during diabetes, we induce diabetes, type 1 diabetes, in mice. So we use streptozotocin drug during 5 days, and then we wait 10 days to start to confirm the glycemia, to confirm the induction of diabetes. and then we start the oral administration of EPA-rich oil, 2 grams per kilogram, and we supplement the mice during 4 weeks. After this period, we induce the wound in the mice, and then we start the analysis. So here I just show you the composition, the fatty acid composition of EPA-rich oil, and as you can see here, more than 70% of the fatty acids in the oil that we used were EPA, so it's really rich in EPA. And we start measuring the concentration of fatty acids in the serum, and we observe that diabetic mice supplemented with EPA, they increase the concentrations of EPA and DHA. And we also observed a reduction in the omega-6, omega-3 ratio in the serum of diabetic mice supplemented with EPA. And in the unwounded skin, we also observed this reduction in the omega-6, omega-3 fatty acids ratio, demonstrating that the protocol, the supplementation, induced the increase in the incorporation of EPA fatty acids in the skin and in the serum. This alteration in the composition of fatty acids in the serum or in skin did not modulate the blood glucose, so the initial glycemia was not affected, and it did not modulate the body weight between the groups. However, the water intake was elevated in diabetic mice and diabetic mice supplemented with EPA in comparison to control mice. This was expected because we know that diabetic mice, as it occurs in humans, we have an increase in water intake, and we also observe an increase in food intake when we compare diabetic mice and diabetic mice supplemented with EPA in comparison to control group. So all these results reinforce that our protocol of induction of diabetes was successful. So after this characterization, we start to investigate if EPA-rich oil could improve the wound healing process in diabetic mice. And to our surprise, we did not see these beneficial effects. As you can see here, the red line is the diabetic group, so as expected, the wound healing was delayed in diabetic group when compared to the control group. And when we supplement these diabetic mice with EPA-rich oil, we also observed an impairment in the wound area 10 days after wound healing. So as you can see here, this is in the control mice, diabetic mice, and diabetic mice supplemented with EPA-rich oil. So the wound area is bigger in this group when compared to the diabetic group, demonstrating that once again, EPA-rich oil has a deleterious effect on wound healing. So I said, why this is happening? And we also observed that this deleterious effect was not related to difference in the concentration of blood glucose between diabetic mice and diabetic mice supplemented with EPA-rich oil. We just saw a difference in glycemia when we compared diabetic mice with control or diabetic mice supplemented with EPA-rich oil in relation to control mice. So it's not an effect due to difference in glycemia. So 10 days, we took the wound tissue 10 days after wound induction to observe the collagen organization, because in the first paper we saw that there was impairment in collagen organization due to EPA rich oil supplementation. As you can see here, we still have impairment in collagen organization because there is almost no collagen in the EPA treated mice, diabetic mice. So with this result, we asked if this tissue could have some functional impairment. So to test this, we test the resistance and the elasticity of the skin of the wound tissue. And as we can see here in red, we have diabetic mice supplemented with EPA-rich oil, and we observed a reduction in the resistance of this tissue when we compared to the tissue resistance from diabetic mice and from diabetic mice, control mice. And we did not observe any difference in the elasticity. So these results shows that diabetic mice supplemented with EPA-rich oil present a wound tissue less resistant to a force when compared to diabetic mice without supplementation. And this was also observed in the wound bed and in the wound edge. So once again, we observe a reduction in the resistance of this tissue, and we did not observe any difference in elasticity. So the tissue is still elastic, but is less resistant. To explain and to understand this effect, we know that the production and the organization of collagen is a result of synthesis and degradation of collagen that is orchestrated by metalloproteinases and metalloproteinase inhibitors. So in this experiment, we evaluate the activity, the MMP9 activity, or the activity of metalloproteinase 9. And as we can observe here, diabetic mice and diabetic mice supplemented with EPA-rich oil, they increase the activity of MMP9 in comparison to control group, but we did not observe any difference between both diabetic groups. So this increased activity of MMP9 can explain the deleterious effect of diabetes during the wound healing, but it did not explain the deleterious effect of EPA supplementation during wound healing in diabetic mice. So to better understand how EPA could affect the collagen organization, we evaluate the expression, gene expression of collagens. And as we can see here, both diabetic and diabetic groups supplemented with EPA-rich oil, they reduce the expression of collagen 1A1 and 3A1 in comparison to control group, but there's no difference between both diabetic groups. We also measure the concentration of MMP9, that is the enzyme that degrades collagen. And once again, diabetic mice, they increase the concentration of MMP9 in relation to control group, but there is no difference between both diabetic groups. So it's not related directly related to collagen, the effects of EPA-rich oil supplementation in diabetic mice during wound healing. So at this part, we have during diabetes, we have a delayed wound closure, an impairment in extracellular matrix formation, an increased MMP9 activity, and the tissue healed, it is less resistant. On the other hand, the supplementation with EPA-rich oil increased the incorporation of omega-3 fatty acids, delayed the wound closure, impaired the extracellular matrix formation, and resulted in a less resistant tissue. So to explain these results, we also performed other experiments such as ELISAs to evaluate the concentration of cytokines and growth factors. And we also performed flow cytometry to understand the cell populations that were present during the wound healing process. So during the proliferative phase that is characterized between the 7th days after wound induction and the 10th day after wound induction, we observed that diabetic mice, they increase their concentration of pro-inflammatory cytokines, all of this, and diabetic mice supplemented with EPA only increase CXCL1 in relation to control group, but there's no difference between diabetic and diabetic mice supplemented with EPA-rich oil in the cytokines. However, when we measured the concentration of IL-10 in the wound tissue in this same time points, we observed that diabetic mice supplemented with EPA-rich oil, they increase the IL-10 concentration in both time points, 7 and 10 days, in relation to control and to diabetic mice without supplementation. So we also observed that this tissue, we have increased percentage of neutrophils, a decreased percentage of macrophage, both in diabetic and diabetic mice treated with EPA-rich oil, but we did not see any difference in the percentage of lymphocytes and fibroblasts. We also observed an increase in mast cell percentage in wound tissue collected from diabetic mice supplemented with EPA-rich oil. This increase in mast cell was related with the increase in histamine, that is a molecule released by mast cells during the inflammation. So diabetic mice supplemented with EPA-rich oil also increased the concentration of histamine in the wound tissue. So to understand which cells we have in the wound tissue, we also performed flow cytometry, tissue cytometry, and we observed that 10 days after wound induction, there is a reduction in CD 206 positive cells in diabetic mice supplemented with EPA-rich oil, demonstrating a reduction in the anti-inflammatory macrophages in the wound tissue, as you can see here. There's less cells than in control or in diabetic mice. So to try to understand, we saw an increase in IL-10 concentration and we saw a modulation of the different cell types during the wound repair. So we asked which cell population could be responsible for the increase in IL-10 production. To answer this question, we performed ex vivo flow cytometry. So we isolate different cell types from the wound tissue and evaluate the production of IL-10. And as you can see here, diabetic mice, they reduced the percentage of neutrophils that produce IL-10 in relation to control group. But on the other hand, diabetic mice supplemented with EPA-rich oil, they increased the percentage of neutrophils that produced IL-10 during the wound healing process. And we did not see any difference in the other cell types, but we also saw a difference in fibroblasts. So diabetic mice supplemented with EPA-rich oil, they increased the percentage of fibroblasts that produce IL-10. However, the percentage of fibroblasts is much more reduced in relation to neutrophils. So considering this difference in the percentage, we isolated neutrophils, peritoneal neutrophils, from mice, diabetic mice, and we treated these cells in vitro with EPA, and this concentration we choose based on our serum fatty acid concentration that I showed before. So we did this experiment, and then we measured the IL-10 concentration. And as you can see here, in basal condition, there's no difference between control, diabetic, and diabetic treated with EPA. So this are neutrophils. But when we stimulate these neutrophils with EPA, when we stimulate these neutrophils with LPS, so we mimic pro-inflammatory condition. The neutrophils that were treated with EPA, they increase the IL-10 concentration. And we also observed an increase in the gene expression of PPAR gamma. PPAR gamma is transcription factor related with omega-3 fatty acid action. So we tested other transcription factors that could be associated with this effect, but we only observed difference in PPAR gamma expression in neutrophils treated with EPA in vitro. So to understand if this if EPA could be acting through PPAR gamma transcription factor, we blocked this receptor, and then we treat the cells with EPA. And as you can see here, when we block the PPAR gamma, we lost the increased effect of IL-10 induced by EPA. So these results shows to us that the effect of EPA increasing IL-10 is due to PPAR gamma activity. And we also tested the effects of EPA in fibroblasts. So we isolate fibroblasts from the skin of the mice, and we treated these fibroblasts with high glucose and high glucose plus IL-10 or high glucose plus EPA, and we measured the collagen gene expression. And as you can see here, there is a reduction in the collagen gene expression when these fibroblasts were treated with high glucose and plus EPA in vitro. And we also observed the same effect when we evaluate collagen 3A1 gene expression. When we blocked the PPAR gamma receptor, we did not see any effect in collagen 1A1, but we also observed a reduction in the gene expression of collagen 3A1 when these fibroblasts were treated with high glucose, EPA, and we blocked the PPAR gamma receptor. So at this time, we observed that during diabetes, we have an increased infiltration of inflammatory cells. This infiltration was delayed. I did not show to you the histology, but because I don't have time, but it was delayed. But when these cells arrived to the wound area, they increased the production of inflammatory mediators, inducing a delay in the beginning of the next phase. These mice, when they were treated with EPA-rich oil, they reduce the arrival of the inflammatory cells and they reduce the production of cytokines, but they increase the production of IL-10. This IL-10 had an effect on fibroblasts, and we observed that in neutrophils, EPA activate PPAR gamma receptor. This activation induced the production of IL-10, and IL-10 blocked partially the expression of collagens by fibroblasts. So EPA had a direct effect on reducing collagen by fibroblasts, but EPA also had an indirect effect on collagen through IL-10 production. So to test if the PPAR gamma activation was essential for the effects of EPA, we also we blocked the PPAR gamma receptor in vivo and performed the same protocol for wound healing study. And as you can see here, when we blocked the PPAR gamma receptor and treated the mice with EPA-rich oil, so both groups, they are diabetic mice treated with EPA-rich oil, but this green line, they represent the mice that were topically received the inhibitor of PPAR gamma, and we observed we observed an acceleration in the wound closure compared with phaco. The area was bigger in comparison to the wound area in diabetic mice treated with EPA plus the PPAR gamma receptor inhibitor, showing that the inhibition of PPAR gamma is the mechanism involved in EPA-rich oil supplementation. We also tested if this beneficial effect on wound healing would reflect the collagen organization. And as you can see here, once again, we almost don't have collagen in the group diabetic mice treated with EPA-rich oil. But when we blocked PPAR gamma, we increased the amount of collagen and we increased the organization of these collagen fibers. We also investigated if this block in PPAR gamma receptor, if this could influence the production of IL-10. And as you can see here, when we blocked PPAR gamma receptor in vivo, we reduced the percentage of neutrophils that produced IL-10, but we did not change the percentage of fibroblasts that produce IL-10. So we have that EPA-rich oil supplementation for diabetic mice delays the wound healing because it increases IL-10 production by fibroblasts and neutrophils, and this IL-10 reduces collagen production. Mechanistically, we demonstrate that in neutrophils, EPA induce the activation of PPAR gamma, then result in the reduction, in the increase in IL-10. When we blocked the PPAR gamma receptor, we reduce IL-10, and then we accelerate the wound healing process because we reduce IL-10 and we increase collagen production. So based on these results, we start our study with a group in Surrey, the University of Surrey in the UK. It's a clinical trial. And they have some patients that received immune nutrition and the other group with the control nutrition. So this patient received the immune nutrition 7 days before the surgery and 7 days after surgery. And they measured some the concentration, the incorporation of omega-3 fatty acids, and the concentration of IL-10. As you can see here, when we compare the composition of red blood cells between baseline and the day of surgery, so 7 days after the supplementation with immune nutrition, we observed an increase in EPA and an increase in total omega-3 fatty acids in red blood cells. This increase resulted in a reduction in the omega-6, omega-3 ratio when we compare the baseline, so before supplementation and after 7 days of supplementation, so reinforcing that this supplementation was effective to induce changes in the serum composition. And although we did not observe any difference between control and supplemented individuals, when we stratified the individuals that did not present complication after surgery and individuals that present severe complications after surgery, we observed that in this group that had severe complications, they present an increase in EPA incorporation in red blood cells compared to the individuals that did not present any complication after surgery. And the same was observed for IL-10 concentration. So we observed an increase in IL-10 concentration in the patients that present severe complication after surgery in relation to the patients that did not present any complication. So, in conclusion, we have that EPA-rich oil supplementation delays wound healing in diabetic mice through increased production of IL-10 and impaired collagen organization in the repaired tissue. These later effects result in a less resistant tissue that can favor new damage to the healed area. EPA also increases IL-10 production through PPAR gamma activation in neutrophils, and we observed that the inhibition of PPAR gamma pathway reversed the deleterious effects of EPA rich oil supplementation in diabetic mice. So we expect that the present study sheds some light in the role of nutrition in treating the wound healing during diabetes. So I would like to thank for my group, mainly Beatrice Burger, that is my PhD student responsible for this experiments. My collaborators in the UK, Professor Philip Calder from the University of Southampton and Professor Fernando Martinez Estrada from the University of Surrey, and my collaborators in Brazil at Unicamp and at USP. Thank you for your attention. This is my financial support, mainly FAPESP. And this is Limeira, and this is my universe. So I'll be happy to be in contact with you. Thanks for your attention.
Thank you, ma'am, for this enlightening session. We are highly privileged to have you in this international webinar meet, and your whole talk was one of the most important talks of our this National Nutrition Month. So your talk has been focusing on the anti-diabetic effect of EPA. So my first question is, ma'am, that generally when studies are conducted, we almost, or even the RCTs also, they try to conduct the study cumulatively on EPA and DHA. Okay, so you have conducted a study on EPA only. So how much that factor may affect the result of the anti-diabetic effect of studies in this case? Okay. Can it affect the result drastically or not?
Yes, I'm not sure if I totally understand your question, but we have the experiments with DHA, but we decide to separate the effects of DHA and EPA, because as I demonstrate in other groups, they also demonstrate that it's better when we study one of each fatty acids isolated, because they don't have the same effects. So for wound healing, both fatty acids, they delay the wound closure. We also demonstrate this with DHA. We already published these results. And once again, we see that it's important for in nutrition field, it's important to separate EPA from DHA. So it's better than put both together.
Okay. My second question is, there is still a dilemma regarding the beneficial role of EPA in human health.
Yeah.
As such, because most of the RCTs conducted has shown the opposite effect as your study demonstrates. So, I mean, in this ground, what is your take about the overall result and overall study?
Yeah, I think it's really, I can say to you that it's really difficult to publish a paper that demonstrates that EPA or omega-3 fatty acids are not good for health. But this is our third paper showing that omega-3 fatty acids, DHA or EPA, they do not improve the wound healing process. And we are not alone. In this paper, we demonstrate that IL-10 is one of the molecules involved in this deleterious effect. And some other groups, very important groups in the field, they also demonstrate that IL-10 is not good for the wound healing process. So it's not easy, but I'm very confident with these results, because we have seen this for 10 years. I studied this fatty acids for wound healing during 10 years, and we always see the deleterious effect. So I believe that in science, there's, I don't know, there's, it's difficult to publish a negative result. So we only see positive results. And we need to change this because result is result. So
yes, you have done the experiment and you have got that, so you have got it. Okay.
Yes. And I think that we proved using different tools that this is a deleterious effect. So we need to think about it, because I don't know in India, but here in Brazil, people used to take supplementation of omega-3 fatty acids. It's very common. Everybody here takes supplementation with omega-3 because omega-3 is good for everything.
Yes,
and
I the plethora of health benefits, and in our country we mainly consume the fish oil. Means there is a lot of types of fishes highly rich in omega-3 fatty acid, omega-6. So it's a trend. Means it has been published. Means still means in clinical trials it has been not been shown or have not shown promising results.
Yes.
My another question is, in case of diabetes, EPA have not shown promising results in regulation of glycemic index. Okay, it has been seen in papers. I have seen that in type 2 diabetes especially. While in opposingly, for prevention, they have shown highly pleiotropic effects. These two are contradictory in almost these type of studies. How can this phenomena be explained?
The contradiction
between the negative correlation between glycemic index, but they have high positive pleiotropic effects in case of immunological pathways, especially.
Okay. Yes. So type 2 diabetes, the main factor is the resistance of insulin, and some studies demonstrate that omega-3 fatty acids, they reduce the insulin resistance. And so this is one of the beneficial effects that EPA rich oil can induce for patients with type 2 diabetes. I think that there's, I don't remember if it was last year, but there's a meta-analysis showing that omega-3, it's not, it reduces cholesterol or triacylglycerol, but it is not as good as we used to think it was. So I think that we need to, it's really important to separate EPA from DHA because of this, because they don't have the same effect. So if you have some supplementation with an increased concentration of EPA, we can have some results that we don't see when we use an increased incorporation or increased concentration of DHA. So once again, I think it's really important to separate what is EPA, what is DHA, because these are the main fatty acids found in the fish oil. And these effects could explain beneficial or no effects on type 2 diabetes.
How far can EPA be effective as therapeutic strategy against insulin resistance phenomenon?
How far
can EPA be effective as therapeutic target against insulin resistance particularly?
Okay. Yes, it could be because PPAR gamma is one of the receptors involved in the EPA effect, and PPAR gamma can also modulate the insulin resistance pathway. So if we have the activation of PPAR gamma receptor, we reduce the production of pro-inflammatory cytokines. And pro-inflammatory cytokines, we know that they act on the insulin receptor signaling pathway. And if we reduce inflammatory cytokines, we can improve the insulin response. So EPA can, one of the pathways that EPA can modulate the insulin response is due to PPAR gamma receptor.
Okay, thank you, ma'am. My next question is, last year, Professor Calder has given a lecture on this topic only, means related to fatty acids, okay? Omega-3 fatty acids. But he said that in the human system, the ratio of omega-3 and omega-6 is very much important for the overall beneficial effect in humans. Okay, especially in RBC membrane, because the RBC membrane composition is mainly determined by the intake of these, means the EP and DHA fatty acids in the human system. So means beside this also, means in other disease also, you are saying that if we can take EP and DHA in solitary or solitude, that would be a much better option, or not?
Sorry, I don't understand.
If we take EP and DHA alone in different amounts, okay, would that be better? Or if EP and DHA in combined, that would be better in some specific ratios?
Okay, yes, I believe that it's better if you have, if you supplement or if you eat in a separate source, because we don't know exactly how each one acts on different cells or different conditions. So I still believe that it's better, at least in the science, for studies, okay? Of course, that for the population, I used to say, okay, eat the fish. I think it's better than to take the pills. So everybody, of course, it's easier to take pills than to eat fish. So at least here in Brazil, we don't eat fish a lot. And for the population, I used to say eat fish. And in fish, we have EPA and DHA, of course. But for these studies, I believe that it's better if we separate the fatty acids, because then we will have the effects of each one that could be the same, but could be different, could be the opposite. So I think to understand the effects of omega-3, it's better if we separate these two fatty acids.
Okay, ma'am. Thank you very much for answering all the questions. So today is the last day of our seminar, and we are culminating it with your auspicious lecture. So I will now pass to our Polidhar ma'am, who will give the vote of thanks and put an end to this lecture series. Thank you.
Okay, thank you for the invitation.
Thank you very much, Professor Rodrigues, for accepting our invitation. Thank you very much.
Thank you. Sorry for the dog. I wasn't expecting to give this talk from my home. Thank you very much. It's a pleasure to be here. So feel free to.
If you come to Kolkata, then we will meet.
Yeah, for sure.
Okay.
Thank you. Bye.
Bye. So it's ending, and teachers, my dear students, and all the registered national, international delegates from across the world, on behalf of the Department of Home Science, University of Calcutta, as the coordinator of the third international webinar 2022 on the occasion of Nutrition Month, I express my sincerest gratitude to all of you to convene on the virtual platform and become a part of curative journey in nutritional science. Thank you all.
I didn't understand that.
Bye.